हेलो। राम गोपाल, वहाँ से आउटपुट बढ़ा दो, लेवल बढ़ा दो। तुम लोगों को कोई बात, वो
रमेश,
आउटपुट
मेरा
लेवल।
ऑडियो आ रहा है?
हाँ सर, ऑडियो आ रहा है मेरा।
क्या मुझे सुन सकते हैं आप लोग? हेलो,
अच्छा ठीक है, रहने दो, ऑडियो आ रहा है। तुम आउटपुट वो कर दो।
मेरी आवाज जा रही है आपके पास? 1 2 3, कैन यू हियर
रम,
मी?
रमेश रमेश
हेलो,
रमेश,
हाँ।
मेरी ऑडियो आ रही है?
जी सर, आ रही है।
अभी सर के चेक करना, दूसरा माइक है।
हैं?
मेरी आवाज आ रही है?
ये माइक का ऑडियो और भी क्लियर है।
तो क्लियर कौन सा है? हेलो।
सर रमेश, ये वाला ऑडियो ठीक है? रमेश रमेश हेलो
में ऐसा इसमें कुछ बोलोगे रिप्लाई नहीं आता, दिस व्हाट इज हैपनिंग।
हेलो रमेश, हेलो हेलो हेलो
अगर आई अगर पेशेंट इज रेडी वी कैन वेट, बिकॉज़ वो ओपन करना पड़ेगा
हेलो
पीडियाट्रिक का रेडी।
हेलो
वी कैन डू इट एक्चुअली, बट कुछ थोड़ा दिन और करना हो,
हेलो हेलो हेलो
सिस्टर उसको लाइट के आगे से हटा लो। पुल
हेलो
अप,
हेलो
पुल द टेबल अप।
हेलो हेलो
पहले चेक नहीं किया आप लोगों ने?
हेलो हेलो हेलो
पूरे फिनिश से पहले चेक
हेलो
किया?
हेलो
नहीं दे नहीं, should have checked with you also.
हेलो 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 माइक चेक 1 2 हेलो हेलो हेलो
Don't wait too much between the stations.
ये आ रहा है? हेलो हेलो, ये आ रहा है?
हेलो हेलो
ठीक है, ऐसे तो होल्ड करो। तो स्टार्ट करो यार। हेलो, कैन यू गाइस हियर मी? हेलो रमेश,
यस सर।
रमेश मेरी आवाज आ रही है आपको?
सर आ रही है, ऑडियो आ रही है आपका।
और सुरेश भी है क्या? सुरेश है वहाँ पे?
सर ऑडियो आ रहा है आपका अभी, ठीक है, ऐसे ही रखने पे किए।
ओके, कैन यू हियर मी? उस साइड पे डॉक्टर कौन है यार वहाँ पे? किसी डॉक्टर से बात कराओ मेरी वहाँ पे। गुड। समझ गया मैं। ठीक है, ठीक है। We online? Okay. So welcome to the live surgery session from the center, and it's my privilege to perform a surgery in front of you guys. We begin the refractive surgery session while
Good morning, everyone. On behalf of RPC family, myself, Dr. Prafulla Maharana, welcome you all to the live surgery session of 58th Foundation Day celebration of RP Center with the theme Legacy. And the first live surgery that we are going to demonstrate is Smile by none other than our Professor Sudarshan Khokar, sir. And he is the chairperson of the current scientific program that we have curated. Sir, please, I think we can see you live, sir. Can somebody tell us the details about the patient?
sure, by the
Good morning, everyone. So here's a patient, 29-year-old female with a history of using spectacles since last 12 years. Now she wants to get rid of glasses for cosmetic reasons. Her power of glasses is stable for last 2 years and there is no history of any contact lens usage. Her anterior segment evaluation and fundus evaluation was within normal limits. Coming to pre-op refractive data, her refractive error in the right eye is -4 diopter sphere with a minus zero point 0.5 diopter still at 120 degree, and the left eye it is minus 3.5 diopter sphere and minus 0.25 diopter still at 180 degree, and her BCVA was 6.6. Keratometry is in the right eye 41.5 diopter and 42 diopter, and in the left eye it is 41.4 diopters. Thinnest Phakic in the right eye is 502 microns, whereas in the left eye it is 508 microns. Our D value is within normal range. Our residual stromal bed thickness is 332 microns in the right eye and 350 microns in the left eye, and PTA is nearly 30%. Our bed maps appears fine, and the patient is planned for both lenticle extraction or Isomex platform. Over to you, sir.
So we're going to dock this eye. You have to ensure that the cornea is wet before the docking. For
Good
this
morning,
one,
sir.
Can you hear me? Prafulla? Praful, can you hear
Good
me?
morning, sir.
Good morning. Can you hear me? Praful, good morning.
Good morning, sir.
Good morning.
Sir, we can see the surgeon's view,
You can't hear me.
microscope view. Yeah, now we can see the microscope view.
But can you hear me?
Yes, sir.
Okay, so Prafulla, I'm going to just dock this eye because the kid was getting a little restless, so I'm going to dock it. So what I'm going to do is the cornea should be absolutely wet, which I just showed you. So just before the docking, you should wet the cornea. आप green light में देखिए, please. Look at the green light, please. वो green light आपको देखना है, वही आपकी friend है. So I still have not docked it because now this is gone now. So suction is on. This ring is going to hold the suction, and we're going to cut the cornea now. बच्चे green light में देखते रहना है आपको. वो green light अभी थोड़ी देर में diminish हो जाएगी. When you have one layer of the gas passing on the posterior, the green light actually gets little diminished because the patient can't see and sometimes they get upset, but there's nothing to worry. बच्चे 8 seconds बचे हैं आपके. And there's a second wave which comes in the anterior, and it is about 7.3 millimeters. The previous one was a 6.3 millimeter. So basically 22 seconds and this cutting process is all over. So this how quick this machine is. And if you can buy a newer version of this, which is called 800, it takes about 12 seconds. I don't have any experience. We don't have the machine, but yes, I believe that has a cyclotorsion correction also. So of course that's more advanced, faster machine. So what you see is now the cornea, which has already been dissected using the femto laser. बच्चे आँख नहीं लाएंगे, अब थोड़ा नीचे देखेंगे, हल्का सा नीचे देखेंगे, and just relax. Just relax. She's a banker. She's a bit anxious. Light clear कर रहा हूँ. It's always a good idea to make a little opening in the center so the patient can see the light. What happens with the gas bubbles? Patient will not see and they get apprehensive. See, the moment I open this window in the center, patient is much better fixing the eye. बच्चे ये light में देखते रहना, आपने कुछ नहीं करना. So what I'm doing is I'm going to the 7.3 zone and coming in. And see what I'm doing? I've created a rectangle here. बच्चे मुंह से बोलना नहीं बिल्कुल. Which is lying flat. But the second rectangle I'm going to make again, which I go in the posterior plane, and this rectangle is more longer axis towards the center of the cornea. So I have two rectangles, one lying here and one inside here. Just relax. So can you appreciate that? One here and one here. So I'm going to go for the anterior one first, go inside all the way halfway and split the cornea in one go, and it's gone well. And the energy setting we kept is 26 in this patient because that's what is the standard we use for the, okay. He's a bit anxious, I don't know why. So the second rectangle is like that, longitudinally towards the center. So when I go there, I'm almost trapped into the tunnel. See, I'm into the tunnel. No, I think it's gone the other way. Good. So I'm going to show you how to. I think we've gone into the posterior first. And I'm going to open the anterior. So anterior is here with me. इसमें पेन नहीं होता है बच्चे, कट चुका है सारा कुछ पहले से. So what I did was I did the posterior first and the anterior later. मुझसे आवाज मत करिए आप. चलिए, relax. So it's all cut all around. It's all over. I'm just going to hold it and take it out and show you how it goes. Look down. पैरों में देखिए अपने. So you just hold the lenticle. We can do the hydrodissection. You can do whatever and see how easily the lenticle comes. सामने देखिए, light में देखिए. And that's how the lenticle comes out. And it's a perfect lenticle. Just put a dash into the cornea, into the lenticle. And in the first 50 patients, you should always check the lenticle for the continuity. And once you know what you're doing, there's no point in wasting time. But for the beginners, it's always a good idea. And it massages the ego also that you got the lenticle correct. And the procedure is actually over. You can already see there's no OBL left inside the eye. Some people do wash the interface, but there's no need to wash. Even if you leave it, the OBL ups and light में देखिए बच्चे. And that's about. And this surgery is actually over. And no extension of the incision, no problems anywhere. Okay, this surgery is over, but I'm just going to show you the other eye, which we did about 2 minutes back, in which it was a marking. वो दिखाएंगे फिर वो करेंगे नहीं उसका कुछ. After this girl is really. In fact, last OT yesterday, we had 3 doctors who got their smiles done. In the last 1 week, we've done about 6, 7 interns. So you can see the marking there. Can you appreciate the marking, Prafulla?
Yes, sir.
So those markings were actually for the toricity. There was cylinder, when the cylinder is 0.5 or more, we always do a toricity check and do it. And we realized that post-op period, even if the cylinder is 1.5, the residual stays about 0.25 and the patients don't accept any glasses. So the cylinders can also be corrected on this machine. The only problem with this is it doesn't have a iris registry. We can ship the patient out. So you have to be properly centered. And if you're not centered, you can always de-dock and dock again. When we were doing this surgery earlier, say about 4 years back, the moment we used to dock in, we used to start cutting. But now we know that even if you stop, either redock it, you can again start it and get better results. So with that, I think the surgery is over. And you could see that my, in the left eye, which I did right now, I did the posterior dissection before the anterior because she moved her eye. So it can be worked either way and it goes well. There's no problem at all. And it's very simple surgery, provided you practice it. And this lenticule we use, cap we use is 100 in all patients. So earlier people were using 120. Now when you use 100, you got a 20 microns to give extra power. You can do a higher adapters also. She can get up now.
Thank you, sir. I think now we'll be shifting to main OT.
Yeah, please. Thank you very much.
The next surgery is implantable columnar lens by none other than our chief Professor Radhika Tandon ma'am. And so Dr. Akshara is going to tell us the details about the patient.
So good morning everyone. We have a case of a 24-year-old female who was using glasses since 14 years and wants to get rid of the glasses for cosmetic reasons. The power of glasses was stable for 1 year and there was no history of contact lens users. So the best corrected visual acuity was 6.6 in both the eyes with the refractive error of -5 diopter sphere, -0.75 diopter cylinder at 180 degrees in the right eye. And in the left eye it was -4.75 diopter sphere with -1.5 diopter cylinder at 10 degrees. The thinnest pachymetry in both the eyes was 491 micrometers with an RSBT of 299 micrometers in the left eye with a percentage tissue altered of 40.2%. So the patient was planned for left eye toric ICL.
Over to you, Radhika ma'am.
Okay, good morning everyone. So here I started loading the ICL. So we have the cartridge which has been primed with BSS and dispersive viscoelastic. And then the ICL, you have to check the orientation. Can you hear me? Yeah.
Yes, ma'am, we can hear you.
So the orientation of the ICL, you have to be very careful. Look at the orientation of the haptics. The right leading and the left trailing will have the little dimple to confirm that it is the correct orientation. Make sure it remains well moistened during the loading process. You have to be very gentle. Then we use the ICL holding forceps. Just hold it and gently load it into the cartridge, making sure it doesn't twist or turn. And you also check the orientation again that it is straight. So we'll now drape the patient. As you can see, this is the plunger. So the cartridge is inserted into the plunger and locked into place. A little bit of Visalon. There's an air bubble on the opposite side, so I'm just going to fill that up with viscoelastic. Yeah. Getting rid of that air bubble and checking that the ICL is moving smoothly. Okay. So now coming to the patient. This is a toric lens, so we will be marking the axis. The orientation is supposed to be 11 degrees.
Thank you so much, ma'am. And in the meantime, when the patient is prepared, I would like to update our audience about one thing. Today we are celebrating International Women's Day, and Professor Radhika Tandon is the first women's chief in the history of RP Center. And this entire program has been planned by ma'am. So congratulations, ma'am, for the wonderful program.
Thank you so much, Praful.
One question, ma'am,
Yes.
from the audience. When you will take a call to go for ICL versus Lasik,
Yes.
is there any cutoff?
Yes, so there are few parameters that I indicated. One is, of course, if the cornea is unstable, that is it is showing features which are suspicious of, आप relax, हाँ पूजा relax करो, हाँ अभी आप दवाई डालेंगे, हाँ relax करो बिल्कुल. The patient is a little bit apprehensive because of the bright light, so I am reducing the light. हाँ पूजा देखो अभी आपको लाइट कम करी है, ओके आपको बत्ती की तरफ देखना है, कंफर्टेबल हो, अब लाइट कम करी है, अच्छा घबराना नहीं है. जस्ट गिव मी अ फ्यू सेकंड्स टू गेट द पेशेंट मोर कंफर्टेबल एंड देन आई विल आंसर योर क्वेश्चन. ओके सो आई एम गोइंग टू मार्क. सो पूजा आपको बिल्कुल रिलैक्स रहना है. इट्स अंडर टॉपिकल एनेस्थीसिया, वी प्रिफर टॉपिकल एनेस्थीसिया एंड so this is the pre-marking which has been done, and correspondingly I will be marking the 11-degree axis. So this is the सीधा देखना बेटा, the 3 बत्तियां हैं ना उसके सेंटर में. Very good पूजा, lovely. ऐसे ही देखना बिल्कुल बत्ती की तरफ, शाबाश. So this is going to be the orientation of the lens. Yes. So talking about your question, so if there is a thin cornea, if there is a steep keratometry and it is stable, पूजा आपको हल्का छूने का पता चलेगा. अच्छा आपको सीधा देखना है, ठीक. आप कंफर्टेबल हैं, हम शुरू करें? Yes, I'll start, yes. I think I won't talk right now because patient is little bit uncomfortable, so I'll ask Praful to carry on the discussion and just describe the steps because patient's a little bit apprehensive, so I'll just concentrate on the patient. Yes,
Ma'am, we can take up the discussion part later.
Yes,
on.
yes.
Let's move on to the surgery.
Yes, आप सीधा देखते जाइए, हम शुरू कर रहे हैं, आपको हिलना नहीं है. नॉर्मल ब्रीदिंग करो, नॉर्मल सांस लेते जाइए, शाबाश. बिल्कुल रिलैक्स करो, पूरे बॉडी को शांत रखो, रिलैक्स करो. वेरी गुड, शाबाश. ओके, वेरी गुड. नॉर्मल ब्रीदिंग करो, बिल्कुल घबराना नहीं है. Whistle on. Injected a little bit of phenocaine because she was a little sensitive. So, and then now I'm injecting a dispersive viscoelastic. As you can see, the strands. बहुत अच्छा करा रहे हैं. हाँ, आप बिल्कुल सीधा देखो. आप बिल्कुल झटके से आँख नहीं हिलानी है. थोड़ी देर लगेगी. That's it. Listen on. Okay, अब हम लेंस डालेंगे तो उस टाइम आपको हल्का प्रेशर महसूस होगा. ओके, आपको आँख सीधी रखनी है. ओके, हिलाना नहीं है. वेरी गुड, शाबाश. नॉर्मल ब्रीदिंग करो, आँख सीधी रखो. वेरी गुड, वेरी गुड. शाबाश, शाबाश. नॉर्मल सांस लेते जाइए, बिल्कुल रिलैक्स रहिए. ओके, गिव मी अ सेंस की. बिल्कुल बिल्कुल नॉर्मल रिलैक्स करो, रिलैक्स करो. सो द लेंस इज टेंडिंग टू रोटेट. आई हैव टू बी केयरफुल. I don't want it to rotate inside. Give me the manipulator, please. Give me heel on. Quickly. Manipulator. वेरी गुड, रोटेट हो गया आँख में, रिलैक्स, बहुत अच्छा. आप नॉर्मल सांस लेते जाइए, वेरी नाइस. ओके, मैनिपुलेटर. अब नॉर्मल सांस लेते जाइए. शाबाश, सीधा देखते जाइए, वेरी गुड. Little more heel on. It's very important to check that the orientation of the lens is good. बस थोड़ी सी देर और, लेंस अपनी जगह में है. Just wash please. Oh, yeah. Little whistle on the cornea, please, Punya. Okay, so the haptics are there. Just need to orient the angulation. You can see that there is a marking for the axis. बस बेटा थोड़ी देर और, last few steps. नॉर्मल सांस लेते जाइए, हाँ, टेंस नहीं होना. बहुत अच्छा करा रहे हैं आप, बस लास्ट स्टेप बचा है. Wash please. Yeah, thanks. One second. सीधा देखा, सीधा सीधा सीधा, वेरी गुड. गुड, सीधा देखते जाइए, वेरी गुड. Now just orienting the axis to align the toricity. हल्का नीचे देखो, अब सीधा. Good. So a little bit more angulation from that side. To be careful not to touch the optic. Sometimes the pupil constricts a little, then one can inject a little adrenaline. Now I'm just going to remove the viscoelastic and then remove and hydrate the wound and remove the viscoelastic. सीधा देखना बेटा, शाबाश. Okay, आइए. As you can see, the lens is well aligned, the central flow is in the center, it's well oriented. बस normal सांस लेते जाना, last step बचा है. Can you put on the IOCT to check the vault? Akshara? I can put on the IOCT to check the vault. बस लास्ट स्टेप खत्म. Okay, that's done. VSS. So hydrating the wound, checking the stability, the vault is good. सीधा देखना, very good. थोड़ा नीचे, good. Okay, the wound is secure. We're putting some moxifloxacin and yes.
Thank you so much, ma'am. That
Okay.
was a wonderful display of how to handle an uncooperative patient under topical anesthesia. And there are few questions that
Yes.
we have got through
Yes.
YouTube channel.
Yes.
One is, when would you consider to take up the patient for if there is any post-op rotation of ICL? Beyond what degree you will consider redialing the
Aankh band
lens?
karna. So firstly, to answer your first question about the indications for ICL, it will be if it's a thin cornea, slightly steep cornea, provided the patient has a stable refractive error, that is the ideal candidate for ICL, or if it is exceeding the percentage tissue alteration of 40. So I would say below 470 thickness or PTA over 40, as was happening in this patient, or keratometry more than 47.3. Those would be the indications for ICL. The ICL technology has improved a lot. The lens is extremely well tolerated, excellent optics, and very well stood the test of time. So it's a very good procedure and a good option for patients for spectacle independence. Now coming to the question about the rotation. So if there's a rotation of about 7 to 10 degrees, that's not tolerable by the patient, and also you'd also look at the quality of the unaided vision. So those would be the indications to go in for a rotation.
Ma'am, there is one more question
Yes.
about the intracameral use of anesthesia.
Yes.
Have you had any experience of using intracameral in ICL, Phakic IOL patient, other than cataract surgery?
So usually we don't use the intracameral anesthesia, but as soon as I started, in her case, she was very, very immediately apprehensive, and she was very sensitive right away. So in her, we have used intracameral anesthesia, and we have had to use it in a few patients. It's very safe and can be used for ICL as well.
And last question, which viscoelastic you prefer for Phakic
Yes.
IOLs?
So a dispersive viscoelastic to begin with, because if you put a cohesive viscoelastic, there will be too much pressure in the chamber, and the lens being very delicate, it will not open out and will not even enter the AC. So therefore, a dispersive viscoelastic to start with. Even then, don't overfill the anterior chamber. The strands of the viscoelastic should be visible to indicate that, you could see the little rivulets of the viscoelastic while I was injecting. That is the end point. After the lens is in position, there are people who have different personal preferences. Me personally, I feel it's good to put a cohesive viscoelastic anterior to the lens, because then you have space in the AC. Also, it squeezes the dispersive viscoelastic out from behind the lens, and therefore, when you're aspirating out the viscoelastic, it all comes out more easily. So dispersive to begin with. Once the lens is in, cohesive over the lens.
Thank you so much,
Yes.
ma'am. Thank you, ma'am, for that wonderful display of ICL surgery. Now we'll move on to our next surgeon, which is Professor Nupur Gupta, ma'am, and she will be demonstrating Phacoemulsification with acryl intraocular lens implantation. Dr. Ananya, she is our SR. She is going to tell you about the patient details.
Good morning. We have a 21-year-old male, a student who wants refractive surgery for cosmesis and convenience. He's been using glasses since 2012, and the power has been stable since 2022. His best corrected visual acuity was 6.9 with in both eyes, with a refraction of -14 sphere with -2 still in the right eye, and -12 sphere with -0.75 still in the left eye. His thinness pachymetry was 501 and 498 respectively, and his endo ACD was 3.48 in the right eye, 3.59 in the left eye. White to white was 12.3 in the right and 12.4 in the left. And this is the Phakic IOL that we've got, and the acryl has been manufactured in such a way that at horizontal placement the cylindrical axis is 60 degree. So since the patient's axis is 70 degree, we only need 10 degree of rotation. Over to you, ma'am.
Yeah, good morning everyone. So we have another patient of a refractive Phakic IOL to be done here. You've seen a beautiful surgery. This is another version. So this is an acryl lens. So it comes with a cartridge which has to be loaded with the lens. So just washing with BSS, and then we put a cohesive viscoelastic. This phakic IOL also has a central hole and 4 peripheral holes in the haptic. Loaded in the same way, so as you would have seen in the last case by Professor Radhika, the hole on the right is the leading one, and this has to be firmly tucked beneath the grooves before loading it. And then there are wings on this cartridge which have to be opened, and the lens is gently pushed forward. This is also a toric phakic IOL. We'll go to the patient now. Limbs. The toric marker. So 70 degrees. Just put Vigilant, Parakin and Vigilant. The pupillate is a little less dilated, so we'll use intracameral adrenaline, and we're taking 2 side pods. Parakin? Yes, ma'am. Vigilant?
Thank you so much, ma'am, for the wonderful display of surgery. Just few questions. What are the size of the incision required for these IOLs, and what is the range? Does it give any extra advantage compared to other phakic IOLs available in market?
Yes, that's true. So it has a wider range than the implantable polymer lens, and it is available from plus 10 to minus 25. Also, it can be maneuvered through a 2.2 incision, and the advantage is also that it's a little tougher. So what the studies have told us, it has a better dynamic range when the pupil is constricting and dilating. So the dynamic sizing is not so much changed with this lens rather than with the implantable polymer lens.
Thank you so much, ma'am. So now we'll move on to our next surgeon, which is none other than Professor Namta Sharma, ma'am. And ma'am will be performing a Lasik procedure.
Thank you.
AV team. Shift to karo. Can we have Lasik OR view, please? We have Dr. Chandra Devi, our SR Unit 4, and she is going to tell us the details about the patient. Yes, Dr. Chandra.
Good morning, everyone. Our patient is a 24-year-old male. He wants to get rid of glasses for cosmetic reason. He has been using spectacles since 14 years and he has stable refraction for the past 2 years. On anterior segment examination, everything is within normal limits. And his refractive error is -1 diopter sphere with 0.5 diopter cylinder at 90 degree. And in the left eye, it is -2 diopter sphere and 0.5 diopter cylinder at 80 degree. And his thinness pachymetry is 598 and 596 respectively. And the RSVT is 465.5 and 448.5 in both eyes. And he has been planned for both eye Lasik. His 4 maps refractive are within normal limits.
Okay, good morning, everyone. And, Dr. Praful, can you hear me? So I think the details of the case.
Good morning, ma'am.
Hi. So details of the case, Dr. Chandra has already told you. So can we have the external
Audio. Surgeon's audio, please.
Audio, can somebody?
Yes, now we can hear, ma'am.
Okay, so good morning, everyone. Now we are doing a Lasik surgery. So first you put the patient interface, and this is what you see as the calibration is done. When it is going to be completely 100%, then we'll try to move the patient and then center the eye. So it is important, as was being emphasized earlier also, to wet the cornea, especially before docking. And this calibration has to be up to 100%, and then only you should start the surgery. थोड़ा chair ऊपर कर दें. हाँ. Okay. Okay, so then there's a green light there. You ask the patient to, you can start now. You ask the patient to look at the green light. Is the microscope view visible there?
Yes, ma'am.
हरी बत्ती में देखते रहेंगे जी, बिल्कुल सेंटर में. तो 1 मिनट थोड़ा सा चिन नीचे करेंगे, थोड़ा सा चिन नीचे और थोड़ा सा इसको ऐसे. थोड़ा सा चिन और नीचे, थोड़ा सा ऐसे ऐसे. एक मिनट ग्रीन लाइट में देखते रहेंगे, ग्रीन लाइट में देखिए. हाँ, So the suction is now on and we are ready. You have to press the foot pedal. So this is the femtosecond laser which is cutting the flap. We are working on the Zeiss machine and now the side cut is made. Suction will become off on its own. So then you have to slide the patient's eye to the second eyepiece of the operating microscope. Okay, you can see that it is focused over there now, Praful. Can I have the elevator, please? Okay, we'll shift to the other side. Okay. So, can somebody show this? The shifting of the machine to the other side because the excimer laser is on that side. इसको move करना पड़ेगा.
AV team shows the OT view. Yes.
So this is a swivel bed which is there, and on this swivel bed, the patient moves from one machine to the other. So the flap is already made by the femtosecond laser, and then you have to shift it to the excimer laser machine.
Any particular precaution that should be taken during this shifting of the patient, as we could see the sister in charge put something on the cornea?
So I think Praful, you've said it, that the cornea has to be moist. Here the flap thickness is 110 microns. इसको आगे और करना पड़ेगा. And especially when you do thin flaps, it is very important that these should remain moist. Otherwise also, the cornea should remain moist. Now we've come to the second machine, and that is the excimer laser machine, which is MEL 90. I think the MEL 90 machine has got the best optics as far as the excimer laser is concerned. And there are two red lights and one green light. The patient is asked to look into the green light, and all the three LEDs are matched in the center, and there is a central ring that you can see. So again, now the flap has to be elevated. So it is best to use an instrument which is being shown here. This is a dedicated flap elevator. There is a hinge which you can see, and this flap in one go is elevated like this. Now we come right to the center, ask the patient to look into the green light. Put the tracker on. Can we show on the external microscope the tracker? Anyway, we put the tracker on. This is being shown, the flap characteristics. And subsequently again we get all the LED lights together and we fire. So the refractive error is on the lower side, so the excimer laser will not take time. Flap protector. So it is over. Now subsequently, like to put a drop of water here and smear it. एक मिनट सामने देखना. Very good. Smear it over here. Don't try to put too much of fluid because everything will regurgitate back into the interface. Then go behind this, and a jet of fluid is first put so that you elevate the flap, and then just allow the flap to go wherever it is going. Can I have another one? So I've used another cannula because I don't want to be implanting the epithelial cells inside. So it is best that you use, if you have to use another one, cannula. So if you have to irrigate, then it is best to change the cannulas, because otherwise you will be implanting the same epithelial cells inside. Now with a very gentle hand, because otherwise you don't want to induce tria, especially for thin flaps. The flap is put back in position. And I have this. And of course, we don't do it, but for the beginners, it would make sense even to dry this edge a little bit so that the flap actually gets stuck.
And we have an audience question. When you say thin flap, how do you define a thin flap?
So
And what
thin
is
flap,
the least
yeah.
thickness that you have done?
So this thickness is 110 microns, and a thin flap would be less than 100 microns. So again, one has to be careful while taking out the speculum, because you should not be disturbing the flap at all. So elevate the speculum, take it out, and the procedure is over.
There is a question about any specific things that you notice after the LASIK is done to avoid post-op stria.
So any antibiotic drop, please. So any specific thing to avoid post-op stria, like I said, one is that you have to just allow the flap to go wherever it is. Once you've cut the flap and it is going on its own space, it will find, those microscopic areas from which the strands have been cut. Second thing is, don't be too overzealous about ironing the flap. I mean, again, it has to be with a very gentle hand, because you can induce tria if you are too aggressive about it. And third is that the flap should also not be, the flap should be, in position, and then it should be adequately hydrated. It should not be very dry as well.
Thank you, ma'am, for your wonderful surgical tips. We now shift back to the main OT. We now have pediatric cataract surgery by Professor Sudarshan Khokar. Over to his team for the case overview. Yes, sir, you're audible. Can we have the OT view, please?
Good morning, everyone. I'll be presenting the case of 3-year-old female. Parents noticed whitish opacity in both eyes in last 3 months. Child has a normal antenatal and postnatal course. There is no family history of similar complaints. Upon examination, visual acuity was both eye. Child was able to follow the light, and the pupillary reflex, direct and consensual, were brisk. On lens examination, both eye were having total white cataract, and a USG B scan was grossly inadequate. This patient was diagnosed as both eye developmental cataract, and we are able to capture the optical biometry for this patient. Axial length was 21.24 millimeters in the right eye and 21.4 millimeters in the left eye. Metropic IOL power was coming to 25 in the right eye and 24.5 in the left eye. And we have taken the second eye probe with the 4% of under correction. We'll be planning for the left eye surgery today. And over to anesthesia consultant, Dr. Sachin, sir.
So, good morning, respected seniors and colleagues. So, for this child, she's a 3-year-old female, 14 kg. We have pre-medicated the child with dexmedetomidine to reduce the anxiety, and child was accompanied by her mother inside the OT. After that, we induced the child with 100% FiO2 and sevoflurane. So that way, the induction is better, and after that, we secured the IV cannula and put her on maintenance with fentanyl and sevoflurane, and muscle relaxant we used was atracurium. So I want to just put stress on either we should use IV induction if the cannula is in C2 or inhalational induction, but we should avoid using ketamine as it increases the IOP also, and it is not a good agent. So over to the surgical team.
Thank you, Sachin.
Sachin has a major role because they decide whether we are going to do the surgery or not. So our life is actually this is coming.
remember ABC? Downstairs they changed 3 mics actually. Then it worked. Are we good? Can you guys hear me? Prafulla? Who's on the other end?
Yes, sir, we can hear you
okay,
now.
that's Manpreet Malli, right? Okay. So here we go. So you can see this ant egg kind of thing. Can you see those eggs, ant eggs? We call them ant eggs. So I'm making the first incision with my left hand, which is my non-dominant hand because the eye is still firm. I think it's boring for the residents and the faculty here because they're seeing this right, left and center happening every day, 7 to 8 times in a OT. So I made 2 incisions, 180 across almost, and then the third one here. And initially we used to do the rexis from the side ports, then we realized that the long forceps used to get stuck. So we started making third incision, which is a little bigger than the other one. And I'll tell you why the bigger one is important here. So now since there's no glow, I want to stay in this capsule so that when I cut it, we can measure the size so that the lens can stay good. That's the air. This is 1 in 10,000 Edry. And then we put a dash of Trifon blue in this patient. And there we go. These syringes are all little tight. So I just put a dash there. No need to stain it blue and black. It's all right. You just want a demarcation. All right. Then you wash it off. Then you need a little higher molecular weight viscoelastic, which is a cohesive in nature. So I'm using a Helon GV in this case. So how do you know where's my 5 millimeter? So most of these zonal cataracts, the ring is about 5.5, but I'll throw you a ring on the top. Can you see the ring? That ring is 5 millimeter. Manpreet, can you see the ring?
So it's not visible here. I think we can have the external camera move to the microscope.
Okay,
so
it's
that
not.
the overlay can be seen.
Okay, it's an overlay. Anyway, it's okay. So you have to believe me that this white ring is 5.5. So if you have a ring like that, 99% you'll be okay. So what I'm going to do is I'm going to stay inside the ring. I give a nick from the side port. See, I came from the side port, gave a nick, lifted it up. Now I'm coming with the longer forceps. See, my incision is a little bigger here, so my forceps will not get stuck into the incision, and you can easily go and do a rexis or whatever shape you want and whatever size you want. It's a good thing to go slow for the beginners. And after every 2-3 clock hours, you can hold, re-grasp it and go back again. Okay. So I've held it 4 times. This is my 5th grip. And I have a habit of going a little bigger on the nasal side, which I think always is playing on my mind. So that's a rexis we got. Now second part is the hydration. I'll do a little hydro. And hydro in these patients should be done without the viscoelastic being taken out. It should be with the viscoelastic in situ because it actually cuts. It's like cuts like a femto actually. See, my fluid going in and cutting without the OVD coming out. So ensure that the OVD doesn't leak out. So that gives you a tamponade for the fluid to go. All right, so I'm using biomanuals. My biomanuals are my personal biomanuals, which is 1.2 millimeter opening. So if you use a smaller 1 millimeter biomanuals, then you should have a MVR, which is 1 millimeter. So there should be a disparity, otherwise you'll have a leak. So this is holding well, and that's the other opening. So I'm just gonna go and eat it up, which is the easiest bit. Can you see the ant eggs crystals? Those are hard, firm oxalate crystals. And if you try to hold them in your fingers and crush, you won't be able to crush them. They're hard, they're firm. And see, that's why the suction is getting obstructed, because these small modaks go and they block the opening of my port. See, my chamber is well formed. I picked up this case because this is not a simple zonular or lamellar. This has a little catch-22 situation, because these small globular things can go and get stuck into the opening also. But fortunately, my opening is bigger than their independent individual sizes. So I'm feeding with the left hand and easily doing so. See, normally these small things will not be flying off in the chamber. They are flying off because they have their own body, they have their own independent existence. See, it's getting blocked, I told you. That's why I didn't want a simple cataract lamellar that would have finished by now. But now see, if you have a struggle, you have to make sure that every time you get the piece on the tip, please feed it in. Otherwise, your suction is not going to pull it in. Okay, so before I take the cortex at the back, I like to take all the pieces out. So my side port comes out and goes back again. So does this hand, comes out and goes again. So anything which is stuck at my incision will come to my tip. See, it's not that easy to eat all these crystals. All right, now I'm going to go for the cortex posterior, which is again simple. Machine suction is not good today, but anyway, it's fine, it's going to be fine. You see, this piece should have been eaten by now. No, handpiece is blocked. Recently, we're having problem with the bimanuals. Sister, can you flush it, please? Can you flush them? So maybe those crystals are stuck, but most of the time, just flush it out. And we're going to go back again. So what I'm trying to say that in these patients, although majority of the patient will be soft putty-like material, but you can have crystals which can get stuck. So, and that there's no other option. You have to just eat them up. So you have the posterior layer which is there, which is the easiest part to take out. Are they working now? Okay. So let's see what happens now. So sometimes the cartridge doesn't work, so you can change the cartridge. And normally I've seen it happen in the live surgeries only. Yeah, you can, again, it's getting blocked. It's not the handpiece, it's a machine which is giving. Can you change the cassette? See, this cortex is such soft material, it should have been sucked in. No, I think the handpiece is blocked. Give me the other handpiece if you have. The suction one, please. Infusion is okay, the suction one. So the handpiece has stopped working now, so we have to flush it open. In the meantime, I'll use the other bimanual, which might be a little leaky because that might not be a 1.2 millimeter size. But let me keep, okay, so I've changed this one. All right, this is okay, this is also okay. And you see the difference? Okay, so I'm just taking lamella by lamella from all around 360 because if you leave the cortex, then you have reactions. Otherwise, most of these patients are absolutely clean the next day and you don't have any reactions. All the old books used to say pediatric cataracts throw lots of reaction, not anymore. So I'm going to change my hands now because the cortex is getting stuck inside here. So that's the role of a bimanual and making incisions 180 across so that you can actually go 360 degrees without much ado. This is not my regular cannula, but yeah, this will do the trick. There were few ant eggs and there were few eggshells also. See, it's getting stuck at the tip. Sometimes they're not visible, they're not that big, but they cause an issue. Is there a time warning there?
We are doing okay, sir, for time.
Time is okay, right?
Yeah.
All right. I'll come back again from this side and just, you have to clear the capsule absolutely clear so that when you give a nick on the posterior capsule, there shouldn't be any duality. You should not have any confusion whether your posterior capsule you're pulling, or you got a vitreous coming in, or there's a viscoelastic. So posterior capsule looks clean enough now to me. So now I'm going to do a posterior rhexis. For that, the trick is to fill up the chamber. I'm filling the viscoelastic in the chamber, not in the bag. I'm leaving the bag. So whatever trickled down from the side is good enough, but the bag should not be taut. If it's a taut bag getting pushed posteriorly, more convex, it can actually run outwards. Not these ones will never do that. All right, so I'll come in the center, see how soft it is. I touch it and I just roll the tissue over it and leave it. So see what I've done is I lifted the posterior capsule up and cut it without disturbing the vitreous. Okay, so now what I'm going to do now is to hold that one and go 360 around like I did for the anterior capsule rhexis. So hold it. The scroll up, you need not disturb the vitreous if you don't want to disturb the vitreous. Okay. So I'm going to just go all around 360 degrees. And posterior capsule rhexis is much easier to perform if you can take the fluid out from there. I don't know why she's putting so much of fluid. You can put a dash of Visilon and that should be better. My regular SR has gone on leave, so anyway. So I don't want to make a very small posterior rhexis. All right, so that's what it is. So posterior rhexis has been done. Now, to do the vitrectomy or not, I think in all these patients less than 5 years, if they're not going to be sitting on the YAG, it's best to do a posterior vitrectomy so the scaffold goes away. So I'm going with the cutter facing downwards. All right, let me take the bubbles out first. I'm taking the bubbles out so that you guys can see what I'm doing. Okay, so I'm going to start the cutting now. Okay, so the moment you start vitrectomy, you have to be careful because you have broken the anterior haloid. So the fluid can actually go in and it becomes like a springy or a slinky. The toy called slinky toy, which I think we all know. So vitreous should get hydrated, but should be getting cut at the same time. So I'm doing it, touching the capsule with the cutter facing backwards, so the scaffold goes away. And then change my hands, come from the other side, and does the same. I'll do the same thing now, so that fluid hata do, please. Visilon dal do ek layer, please, for God's sake. Muskan, what do you not understand? Bas, theek hai, kuch mat karna abhi. Okay, so I'm going to cut again. If you notice, the lower part of the rhexis, posterior rhexis, is not round. You can notice this here. And now once I cut it, it will be all the same shape which we created. You don't have to go all the way deep into the vitreous. You can just do a core, maybe a 2-3 millimeters round is good enough. So if you can make a central part of say 3 into 3 or 4 into 4, that's good enough for you. Okay, and the end point is when you see the curling of margin of the rhexis posterior, and the shape is the same which you created. Now I'm going to inflate the bag, and there I go. Now I'm going to push the posterior capsule back all the way, and we're going to show you the retina of this. So we're doing this in all the patients. I'll put a wide angle, and this we've been doing for the last 5 years. We have records of 1 month old to 10 years old kids with the fundus changes, and I hope you guys can appreciate that on that one. Just ilo ka light adjust kar lena thoda sa. Manpreet, can you see the disc?
Yes, sir, we can see.
Very clearly?
Yes, sir, very clearly.
You can see the foveal reflex, everything looks good. So if you have a problem, you can avoid the lenses sometimes. You have a cupping. Now you can see the periphery retina also. You can go actually quite a big distance you can cover. So this is a thing which I think it's happening only in the RP center and not nowhere in the world actually. So we do the UBM in all these patients and we do the wide angle and we can give a good prognosis to these kids now. Okay, now I'm ready for the lens. Lens, you're going to put in posterior rhexis, which is already open, anterior rhexis also open. Okay. You can see the posterior rhexis is round. That's usually round only because that's easier to do. Okay. If you're putting implant in these ones, the trick is not to use a wound assisting technique, rather make a bigger entry. This is 2.8. This is 2.8, please, not 2.2. And my lens will go inside with my cartridge going all the way inside and injecting the lens into the bag. Because I don't want the lens going into the vitreous, because if it touches the vitreous, it might have some strand which comes out and later on can have a problem. We'll just take 2 minutes more. We're almost done. So, and we did a 3% undercorrection that I think already Baiju has told you. All right, so the lens is going in the bag. You see I opened the bag. If you can pull the lower speculum away, the guys can see it better. Yeah. So it's in the bag. I think everybody is doing the same here. But since I'm doing a live surgery, and this might be my last live surgery here, so I thought I'll show off a bit. So lens, lower part, haptic is inside. Cornea flush kar do. Okay. the upper part is still not in. So you just tuck the optic. Once the optic is gone 90%, then you can actually hold the haptic and ease it into the chamber, into the bag, and see how easily it opens up, and see there's no distortion of the posterior capsule. If you want, you can enlarge the anterior axis, but I think it's looking good, no problem. It's not round, but it's good. So that's about it. Now what I'm going to do is I'm going to put suture in the main incision, and for the side port, I'll do a bubble technique, which I think Tushar should get the credit for that, because we planned and we did, and we realized that if the bubble is stable after doing the hydration, you don't have to do anything. I'll just perform that also. So you,
as we are nearing the end of surgery, sir, may I ask what is your preference for undercorrection in pediatric eyes?
Okay. So 5-year-old gets 2%, 2-year gets 5%, 1 year gets about 12 months, 12%. From 12 months to 6 months, we do about a 15%, and less than that, we do 20%. And in case you're not able to perform less than 3 months IOL, it's absolutely fine, because leaving bilateral phakic in these patients is as good as anything else. You can always go for implant. But even if you're not putting implant, I'll still suggest you do an anterior axis, posterior axis, and vitrectomy, so that when you go for the second time, you don't have much problem in doing so. And we have done this study here in which that's why we came out with our own nomograms. We realized that the eyes, Indian eyes, don't grow as much as the Western eyes do. But after saying that, if you have unilateral cataracts, we've seen the eyes which we left plus 10, plus 12 on the table, and 5-6 years down, they come back with minus 18, minus 20, and we have to explant. So those are especially more with the unilateral eyes, and especially when the parents don't follow the amblyopia regime and don't wear glasses properly. So what I'm doing now is I'm taking the visco out. You see it comes out so easily, lens does not move from its position. Is the glow and retro all fine there, Manpreet?
Everything fine, sir. It's looking beautiful.
Just to maybe 60 seconds more, if time is not a constraint, I'll just show the bubble safe technique. Now see what I've done. I've come out from the right side. My fluid is still on, so my chamber is still formed. I remember my senior used to say, when you do something, you should give a message to people to learn from that. So my message is that you should make the air go inside first. Right. All right. Okay. There's a big bubble. So I'm going to hydrate one side and hydrate the other side. I haven't done both, I just one. And you see the bubble is still expanding. Can you see the expansion of the bubble?
Yes, sir.
Okay. So I'll again go to this side, second one here. And it's already stabilizing. So that doesn't mean that you have to leave the bubble inside there. You can always take the bubble out. This is a little bigger bubble, so I'm going to just make it a little smaller than this. So tomorrow when my residents open eye, they can actually do a retinoscopy very easily. And since the suture is buried, there's hardly any reaction in these patients, and they perform very well. So just before I finish, I'd like to go and just touch the lens and see. It looks as if it's not, but the shape of the Rex is like that. So it's in the bag and it's good. And that's about it. Thank you very much.
Thank you, sir. A beautiful surgery as usual. We now shift to Professor Radhika Tandon, ma'am, who will be showing us Phacoemulsification with Alcon Panoptics on the Clarion platform. Over to you, ma'am.
Good morning, everyone. Am I audible? Is my mic on? Yes.
We'll just have a brief case history by Akshara.
So we have a 55-year-old lady complaining of diminution of vision in right eye for 6 months. So she had right eye immature nuclear sclerosis grade 2 with posterior subcapsular cataract, planned for right eye phacoemulsification with intraocular lens and plus 24.5 diopter of Panoptics lens.
Okay, good morning everyone. So the patient is under topical anesthesia. I have made 2 side ports and a central port with 2.2, and the phacoemulsification has been performed, followed by IA, and now we have the bag nice and clear, and I'm ready to insert the lens. I'm using the AutoSir delivery platform. So here we are with the lens. हम लेंस डाल रहे हैं, थोड़ा सा आपको प्रेशर महसूस होगा. अच्छा, आप रिलैक्स कीजिए. Oops, I have to enlarge incision, sorry. Okay, so this happened. My incision was a bit small, so I have to reload the lens. 1 second. This sometimes happens. Okay, the lens is extremely good material and very forgiving for in case this happens. So we'll just irrigate that lens now and then reload it. Meanwhile, I'm just checking why my incision turned out to be smaller. So the Panoptics lens is a trifocal lens. It gives the patient spectacle independence. It has near vision from the 40 centimeter range and intermediate vision at 60 centimeters, and beyond that is the distance vision. It gives 20 by 25 vision in this range from 40 to 60 centimeters.
Ma'am, any difference in the material vis-a-vis the older Alcon material and the new Clarion platform?
Yes, so the Panoptics is now available on the new Clarion platform. There is a modification of the material. They have improved it by in two forms. One is by the material per se. It is more biocompatible, and also modified the hydration or the water content. So this has given it the benefit of eliminating the possibility of developing glistenings, which used to be sometimes a concern with the previous one, though it never caused any problem with vision or any discomfort or inflammation. But still, this Clarion platform is a marked improvement over that. So there are no glistenings, and the Panoptics lens gives the patient spectacle independence. I'll just insert the lens and I'll explain once you see the lens and what is its profile. Okay, so I enlarged the incision slightly using the AutoSert platform. Lens is going into the bag. Sinski. So you'll notice that there are rings on the lens. So this may cause some people concern that there are rings and how does it affect the vision, the quality, etc. However, the rings have been very beautifully designed. There are 15 rings and centrally there is a diffractive zone of about 4 millimeters. And right in the center of that is a 1 millimeter bullseye for the intermediate vision. So the other important modification is that it is on an Enlighten platform. So the Enlighten technology gives patient excellent quality of vision without any loss of contrast sensitivity. There is 88% light utilization, and the light separation is 50% for distance, 25% for intermediate, and 25% for near, which is very seamless, and the patient is able to see clearly at all ranges. So this patient has a very good eye profile. She has no astigmatism, so this is a very good lens for her. She is a homemaker and would like spectacle independence for her day-to-day activities, would like to be free of requirement for glasses. After putting the lens, you have to make sure you have removed all the viscoelastic and the case is done.
Any tips regarding centration of multifocal eyes, ma'am?
Yes. So under topical anesthesia, you will make the patient look at the light and check that the centration is matched. The other thing is that the lens is designed as such to center within the bag. But yes, before finishing, you would like to confirm that the lens is well centered. As you can see here, it is very well aligned. I'm just hydrating the wound. And one could sometimes inject pilocarpine at the end of surgery also to constrict the pupil, but I don't like to do that routinely because you want to minimize the various substances that you're injecting inside the eye.
Ma'am, do you consider angle kappa before deciding for a multifocal?
Yes. Yes, can I have the air, please? Yes. It is better to take into consideration because otherwise the patient can have a little discomfort otherwise. Visual disturbance, yeah.
And what would be your threshold for implanting a multifocal toric?
More than 0.5 diopters of astigmatism, so 0.75 or more multifocal toric. I'm just putting an air bubble right now to stabilize the anterior chamber. I had enlarged the incision a bit more than what I normally keep. I'll hydrate it and then I'll reduce the air bubble. Any other questions, Manpreet?
No, ma'am. Thank you, ma'am, for a wonderful surgery. We'll now now shift to Professor Namrata Sharma, who will be showing us pure C intraocular lens, which is an extended depth of focus intraocular lens. May we have the case summary?
Good morning, everyone. Our patient is 54-year-old female, homemaker by profession. She is diagnosed with right eye immature senile cataract, nuclear sclerosis grade 2, with posterior subcapsular cataract, and she is planned for right eye phacoemulsification plus posterior chamber intraocular lens of 24 diopter pure C lens.
सर पाइलो है, पाइलो दे दीजिए.
Mic is on.
पाइलो और दे दो.
Is the mic on?
Yes, ma'am. Yes, ma'am. You're
Okay,
audible.
so we've already done the rexes, the phacoemulsification. We are now just, and the irrigation aspiration, we are polishing the some of the strands which are remaining on the posterior capsule. And now we are going to be implanting the pure C lens. So just as is imperative before implanting the intraocular lens, you put the viscoelastic, this is a cohesive viscoelastic inside. How do you know it is completely full? When the margins of your capsular rexes actually get blurred. So the whole bag is full, and when it starts to blur, that means the bag is completely full. You have to slightly increase the incision. In these pure C lenses, these are the latest lenses which have come from on a Technis platform. So the platform is great and it is very good. And these are purely refractive design. So there are no rings. It is an extended depth of focus lens. And is the IOCT also on? Okay, it doesn't matter. It's okay. They can show the microscope view. So subsequently, the intraocular lens is implanted. Bas ho gaya. And then this is a screw mechanism, and basically what is done is you hydrate the lens, you advance and you deliver. So it is a lens which the delivery system is very smooth, and we are a part of the multicentric trial. We've done close to 30 plus lenses with excellent results. It gives you very good distance, intermediate and near vision. Viscoelastic, please. So once you implant the lens, it is always good to put the viscoelastic so that the lens settles down in the bag, and then subsequently we can just the haptic which is towards us can just be placed in position.
आपका ऑपरेशन ठीक हो गया है, अभी पट्टी लगा रहे हैं.
Part of it is aspheric, so that takes बस हो गया. That takes care of the anterior spherical abrasions and the posterior parakin, please. सामने देखो. And the posterior part is actually has got the posterior part of the haptic has got the design which is refractive, and you can see that there are no rings. It is a no ring lens, truly extended depth of focus, and we do have very good results of this. Subsequently, we just aspirate the viscoelastic just as we would do normally, both from the anterior compartment as well as parakin dal denge, both from the anterior and the posterior compartment. So I think it is a great, this lens has a great future because it is an extended depth of focus without any rings in it. So, and on a only lens which is available on a refractive platform. You just go behind the lens and then aspirate the viscoelastic from behind as well as from in front. And we've done a study where we found that when you do a double compartment aspiration, the distance between the posterior part of the PC and the
no, it just happens. You see, maybe when I went in the beginning, I wasn't through 2.2. It must be something like that. I know. It never happens like this. I know. It's okay. But in a way, it's good. No? It demonstrated it, and it was so nice to demonstrate that if this happens, not to worry.
Thank you so
and
much,
you manage it so well, you watched it, etc. That's the important thing, no? If you make it too easy, then people don't learn also, no? Like this can happen, then they don't know what to do, then they start panicking. And I showed how it is removed and everything, so it's okay.
And we've done close to 30 lenses, you're supposed to do 40.
Yes. Yeah.
And bilateral implantation is what we are aiming at, and then subsequently we have a 3-month follow-up, and we are looking at the distance, intermediate and
Yes,
the
yes, thank you for
near acuity.
sponsoring the lens for the
So
patient.
far
She's
the
very
results have
lucky.
been really good, and the best part
Okay,
is that there
take
is
care.
there
Thank
are
you,
no
thank you.
dysphotopsias because it doesn't have a ring. BSS or
Mhm.
it doesn't have
Thank you
any
so much.
rings.
Thank you.
So that part is taken
Oh.
care of, and the platform is Technis. So same as that of Technis. So the platform is also time tested, and there was a study where it was shown that even this is going to come on Toric platform. It is available, and the Technis lenses are rotationally found to be very stable. This is intracameral moxifloxacin, which we do use in most cases. Again, we have done a randomized control trial of how many thousand patients, Chetan? 26,000 patients, where we have found that it is good to use intracameral moxiflox, and this paper is again being accepted for publication. So thank you very much.
Ma'am, I think we'll do a little bit more discussion here.
Okay.
So,
Did I finish fast?
Yes.
Oh.
So the IOL insertion was quite smooth. So what is the incision size and what are the device?
So the incision size that we use actually is 2.2. I do like to increase just a little bit because I'm using the screw mechanism, although you can still put it when you do by wound insertion. This patient was a little uncooperative, as you would have seen, and so that is why I didn't want to struggle on a live surgery during the implantation of the lens. But I would like to talk about the lens. Can we see the lens carton, please? So can you show it there? This is the pure C. Can somebody take a picture? This is the pure C intraocular lens, and I truly think that this is the lens. You know, this is a great lens, mainly because of the fact that it gives you the visual acuity at distance and at intermediate, and it is a no dysphotopsia lens. There are hardly any dysphotopsias which are present. In future, I do think that the lenses without the rings would probably be the future of multifocality, but I know that all the lenses, of course, which are multifocal or extended depth of focus lenses are doing well. Having said this, I think it is very important also to know what the occupation of the patient is and what is the requirement of the patient, and vis-a-vis the expectation of the patients. So if the patient expectations you are able to meet, and like it is always said, you should under promise and over deliver. But I think with this lens we don't even have to under promise, it over delivers. So it is much greater than actually, if you say you know, what I had expected. So as far as the intracameral moxifloxacin is concerned, there have been many studies, mostly retrospective in nature. We have a database from Arvind Eye Hospital, 1 lakh eyes. Then we have 6 lakh eyes, again retrospective analysis. But this study that we did again was a multicentric study, taking 26,000 patients, where in one group we did put intracameral moxifloxacin, and the other group we did not inject intracameral moxifloxacin but used topical moxifloxacin post-operatively. And we did find that there was statistically a significant difference between the two groups, and so it is worthwhile to put intracameral moxifloxacin. Having said this, we also need to be aware of the fact that the organisms will become resistant to moxifloxacin over a period of time, and so probably you would need another antibiotic.
One last question, ma'am. The market is flooded with EDOFs and multifocals of all sorts. So any patient selection criteria you follow in EDOF vis-a-vis multifocal?
So I think basically, like I said, it is very important to know what the patient is looking at and what the patient's requirements are. So if the requirement is near, then you would go in for a different kind of a lens. If the requirement is more for distance and intermediate, then again you would go for a different kind of lens. And as far as we are concerned, we don't actively counsel the patient for a particular type of lens, but we give them all the options, and also counsel them only about, you know, what they are going to get after a particular lens. Having said this, because this is a government organization, I think the economics also play a very important role, and some of the patients would opt for lesser would opt for lenses, you know, which are not that expensive. But again, we've tried all kinds of lenses, and I think it is best multifocality, or the lenses which would take care of all your distances are going to be the future. And Clarion, and I think the material of the lens is going to be similar what it is now. It is not going to change. Only the platforms are going to get better and better.
Thank you so much, ma'am. We now shift over to Professor Khokar, who will be showing us AIIMS, another lens with enhanced intermediate vision. Over to his team for the case summary.
So this is the patient, 66-year-old female with a history of gradual painless and progressive diminution vision. Since
Can you guys hear me?
in the left eye, she has a history of
अच्छा वो बता रहा है
2 years back, and right eye cataract surgery was done 6 months back. Upon examination, right eye is 6/6 and the left eye is finger counting at ½ meter. Intraocular pressures are within normal limit. She is having a cataract of nuclear sclerosis grade 2 with posterior subcapsular cataract in the left eye, and both eye retina is attached, and currently planned for left eye cataract surgery. She is having a toricity of 1.72 TK in the left eye and planned for left eye AIIMS toric for now. Over to Khokar, sir.
Okay. Yeah. Hi guys again. Can you guys see the camera view? The microphone view is visible to you guys?
Yes, sir, you are audible
okay.
as well.
So I marked it's 100. This is a toric one, and sorry, it got a little delayed because this patient had to be blocked. She's undergone VR with a buckle and surgery. Okay, so I've done a rexis. So the problem in these patients post vitrectomy and all these surgery is the eyes move a lot. So what I'm trying to say is it looks as if the lens is moving all over. So you have to ensure that your hydro goes well inside the bag and avoid putting any fluid into the sulcus, because that can actually jeopardize your zonules more in these patients. And I don't want the lens to get dislocated. So I'm doing very gentle hydro at multiple layers, and my golden ring is visible now. The lens is trying to stand out, but it's not freely rotating right now. Okay, so give another nudge. All right. So let's go without rotation. Once you got a vitrectomized eyes, there's always a challenge because there's no thrust from the back. And if you overfill, can you stop talking in the OT? Okay. So I've put in Phakic now. And my aim will be to hold the lens nucleus and take it out first and then chop, rather than pressing myself downwards. And okay, so we're using these machines, which are good machines. I think we've been using for so much time. All right, so there I go. See, the depth of the chamber is so high. And I'm going to take this piece, hold it, wait for the machine to occlude. It's not holding very well. Okay, I'll try again. Hold against the wall. So if the eye is soft, sometimes you can't get a primary chop. So I couldn't get a primary hold. So what I'm going to do is I'm going to go into the gutter and split it open. So soft eye, high myopia, post vitrectomy, you might not be able to get a primary chop. But now I can split it easily. See? And I'm just eating it piece by piece. And my settings are 0 to 50, and these machines are really good. And I picked up this case because this patient was post vitrectomy. So one piece gone, second piece is at my tip gone, and the rest half nucleus is still inside. So you can rotate it again. So this bag is a little dicey. That's why I wanted to show this to for the resident's sake, that in these patients also you can actually manage. See, I'm not pushing the bag out, I'm just taking the piece anterior, and my chopper is in front of the piece so it doesn't come and hit the cornea, and just finish it off. So the nucleus is gone. Epinucleus is a rock and roll technique. Just hold it and roll it. Hold it and roll it, and you realize that everything comes to your tip. All right. Have you planned a CTR for this one? Yeah. So we might use a CTR because we found the bag was a little lax. All these patients, especially in the old age when they undergone VR surgery, lens can be put, and rexis also can, the CTR can also be put. So sometimes the CTR you decide on the table. In this patient, let me take the cortex out and see. I'm doing a coaxial, but you can do a bimanual also in this very easily, because if the bag is little lax, it's better to do a bimanual. I think somebody was asking me a question right now, that why do you use a bimanual in pediatric? The trick is because you need to go 360. All right. Okay, here we go. So coaxial also works equally well. So the cortex is out. See where my posterior capsule is. It's almost in the mid-vitreous. You can see where it is. Can I have some polish, please? So what I do is I go on 10 suction, 10 aspiration, and I can actually put my foot pedal down all the way down without keeping my brain teasing that how deep should I press my foot pedal. With the capsule polish, I can go. So that's clear enough now. All right. And you can see the breathing pupil. Every time you come out, the chamber goes shallow and it goes deep again. So we have a CTR. Okay, anyway, let's put the implant. I think they're not planning CTR. Okay. Let's anyway, we can avoid also. Otherwise, if you can put, because this bag was a little mobile. Okay, can I have the lens? I'm putting a lens which is a toric lens. I already marked it 107, and we put the data on the aura also. And large incision? Yes. Okay, give me the blade. Yeah. So I'm going to treat it like a pediatric cataract. I'm going to enlarge the section from 2.2 to maybe a 2.3, and that should be enough. What happens now that the lens can easily go in and not like a wound assisted one. See, it's still tight. I haven't gone all the way in, but my lens is coming in very well. And this is an AIIMS Toric. I've been using this platform for the last, I think, five years now. And one, it's a clear lens. And I like this lens. And it has asphericity to cause the EDOF, the depth enhancement. Meaning that it doesn't have the rings which are diffractive rings. Whereas the other ones will show diffractive rings, which may work in few patients, but in some patients, they can cause a problem because of the glare and things like that. So we're going to run the aura in this one. Can somebody put a mic on, camera on that one? Tushar, the chamber is rather deep. Okay. So the lens tilts to the side and the viscoelastic comes out. I used the cohesive one here. So let's see if I can pick it up on the aura now. My viscoelastic is out from the chamber. I'm almost at the point where I should park my lens. I'm going to lock it here. I could have done it before putting the lens, but these guys, Shivayan, nobody was at the aura. Anyway, now I think I'm going to close it up. I don't need aura now because you didn't take the reading before. Okay, so this is a spot which is 107 here, 110, 107, BSS ortho. So all these eyes need to have a proper hydration. You see again the chamber is going shallow. Yeah. So you go into the side wall of the incision, main incision, and make a ball about 1.5 millimeter, and chamber goes deep. No, we're good. So I'm going to just nudge this lens, and you can just park it here. So that was 120 mark. There was 110 here. So we are in between 110 and 1.5 and 110. So it's about 1.7. And I think we're going to call it a day. Antibiotics, please. At this stage, I always put antibiotics, but I put the antibiotic into the bag, pushing the lens down and into the bag. Oops. There's always, these are the new syringes we got, which send you air even if you don't want them, fluid orgy. You know. And that's about end of the surgery. Now something about the lens, we've been using this toric lens of Johnson's for a long time, AIIMS, and it doesn't have any rings. So none of my patients have actually complaints of rings ever in these cases, and you just tuck it into the position and leave it alone. So that's about it. And anybody wants to ask any question about this lens, I'll be.
One question, sir.
Please.
AIIMS toric can be notoriously challenging to align along the target axis. So, any
Yeah.
surgical tips for that?
Okay, so what you can do is you can go parallel to the line which you've drawn. So here also I left it parallel. If you're at an angle, then you can go wrong. See what happens, all these markers are basically for the Western eyes when the eye is big. So that happens with most of the lenses, that when you put the marker across, the eye is big, whereas the Indian eyes are smaller. So there's always a little misadjustment, or you can call it a parallax, which you have to remove. So once that is settled, it's fine. So if you're parallel to the line which you marked, then it's all fine.
Thank you so much, sir. We now move on to Alcon Vivity Clarion by Professor Namrata Sharma. May I have a team give the case?
Good morning, everyone. Our patient is 55-year-old gentleman, businessman by profession. He is diagnosed with left eye immature senile cataract, nuclear sclerosis grade 2, with posterior subcapsular cataract. It is planned for left eye phacoemulsification plus posterior chamber intraocular lens, Alcon Clarion Vivity.
Over to you, ma'am. Ma'am, you're not audible. Can we have the audiovisual team sort out the mic? Ma'am is doing phacoemulsification while we sort out the mic. You can see that rhexis has already been done and she's in the middle of chopping the nucleus.
Oh.
Yes, ma'am, you're audible now.
Okay, so we are nearly doing the phacoemulsification. Are they focusing on the IOCT?
Yes, ma'am, we can see both the IOCT as well as the microscope view.
Okay, so we are doing now phacoemulsification. This is a grade 2, almost a grade 3 cataract. Rhexis has been done, incisions made, and now we are doing phacoemulsification on the Centurion machine. And I think we've worked on this Centurion machine for many years now, and this is the machine with the active sentry. Gives you a absolutely great control of the anterior chamber. The fluidics are excellent, and the active sentry or the surge detector is actually present in the handpiece itself. So it will tell you how many times the active sentry was used to mitigate the surge at the end of the surgery. I did use Viscoat in this case because of the grade of the cataract, which is a little on the harder side. And just as you come to the last pieces, you can possibly also do epinucleus, because the chamber kind of becomes loose, the AC becomes loose, but notice that the surge is not there, and I think that is the beauty of this Centurion machine. Can we have epinucleus, please? So we are now on the epinucleus mode. Just as you finish, it is best to actually do with the instruments like this, so that there are no fragments which are present at the side port or in the main incision, which generally happens in cases of hard cataracts. Now you notice that the PC is actually moved up on the intraop OCT microscope, and that would happen because of the pressure which is there, and as you put the viscoelastic, the PC actually moves down, which again can be seen on the intraop OCT microscope. And we like to use coaxial, although you can use coaxial and bimanual both. I feel the coaxial is faster, and especially on the Centurion machine, it is really very effective. So it is important to pull the anterior left leaflets and not get tempted by the posterior leaflets. So the posterior is also there, but I'm just pulling the anterior ones, because like a handkerchief, if you put the pull the anterior one, the posterior will come on its own without actually having to go towards it. The pupil is slightly coming down, but can we have polish? So I'm using this polish mode just to detach some of the cortex that is there. Can you have cortex? And now this is the 12 o'clock. Can we have polish again? So there's a small fragment there which just needs to be scratched a little bit, so that, and I think it is done. Now we are going to put the viscoelastic, and like I said earlier, notice how the posterior capsule is again moved up. But as I put the viscoelastic, and how do you know it is completely filled up? Of course on the IOCT you can see, but as you fill up the bag, the margins will become distinct and then they will become blur. So once they become blur, you know that the viscoelastic is spilled out of the out of your bag. Now this is the Alcon Vivity IOL on the Clarion platform. Much has been talked about it already. The best part is that this is the only intraocular lens which has got multifocality, which works on the wavefront technology. It has UV filtering light, blue filtering light, both. The depth of focus gets extended, and beyond beyond 44 centimeters. Beyond 44 centimeters, the whole focus is extended. So the patient has a good distance visual acuity, has a good intermediate visual acuity, and has a functional near activity. So it is the stretching of the focus, and there is a 2.2 hump which can be seen in the center, and that is actually where the wavefront technology is working, and it has stretched the focus in that 2.2 millimeter zone. Again, the viscoelastic is aspirated here. Can you put cornea some? Viscoelastic is aspirated both from anteriorly, and we can also try to do it posteriorly. Again, the viscoelastic, it comes out from the posterior part and from the anterior part both. And can somebody show the distance between the lens and the PC? So you can see that the distance between the lens and PC actually would decrease once the viscoelastic is out. And can we see the 2.2 millimeter zone where the whole focus is extended?
Yes, ma'am.
And
yes,
this is the X technology, or the wavefront technology, which is unique to this lens. I think you can see the hump there, 2.2, and it gives really excellent results and excellent vision.
Does it, like the rings, contribute to any dysphotoptic symptoms, ma'am, or is the lens largely free of glare and halos?
No, it is largely free of the dysphotopic symptoms, because it doesn't have any rings, and it is only the depth of focus which is extended using a wavefront technology. So the patient is independent of glasses generally, and I think it is a great lens, especially because the intermediate and the distance both are taken care of simultaneously. As you see, we have hydrated the wound. There is a spindle there, and both the anterior and the posterior parts are actually opposing, and you know that the wound is completely closed. So if there are any other questions, I would be happy to take them.
$1 million question, ma'am. You have showed us 2-3 technologies. Which aisle for your eye, if you require it?
So I think I am still young. waiting for the not going to get cataract for next few years and waiting for, you know, something really exciting to come. But I think Clarion is a great platform, and I think Manpreet, you would have got the hint. And
Yes, ma'am.
it is a platform which has no glistenings, and also I think it's an excellent lens. Clarity-wise, it is too good.
Thank you, ma'am.
Did I finish fast again?
Yes, ma'am. We have to think of questions for you, ma'am, to keep up with you.
Okay, that is why you asked me this question, which
Yes, ma'am.
you shouldn't have. I mean, I'm not.
No financial interest, ma'am. Thank you so much, ma'am. We now move over to Professor Tushar Agarwal, who will be showing us pure C intraocular lens. Over to his team for the case summary.
So we have a 53-year-old gentleman with both eye diminution of vision since last 6 months. Patient has a right eye vision of 6/36, improving to 6/12, and left eye 6/36, improving to 6/12. Fundus seems within normal limit. So we made the diagnosis of right eye immature senile nuclear sclerosis grade 3 with dense PSC and left eye IMSC NS2 with PSC. We have planned the patient for right eye phacoemulsification with EDOF foldable IOL under topical anesthesia. Over to you, sir.
Sir, you are not audible. We'll just work on the mic.
Polish system. आइए मनप्रीत माइक ऑन है क्या?
Yes, sir. Yes, sir. You're audible.
Okay, okay. So I've just finished with the cataract part. I'll be implanting a pure C EDOF lens. So it comes preloaded, and so incision size is 2.2, but manufacturer recommendation is 2.4. So I'm going to enlarge it a bit.
Any OVD preference for loading the IOL, sir?
Sorry?
Any OVD preference in loading the IOL? Is it loaded in BSS or
No,
do you prefer
in viscoelastic, in
okay.
methyl cellulose.
In methyl cellulose, okay, sir.
I think you can use Visco-Ot also, but a slight bit of enlargement just to, you know, make sure that the lens goes in. Little bit of extra pressure is required compared to the AutoCert, of course. So the eye moves down a little bit, so I'll reduce the magnification. So normally I try to bring the lens almost till the edge and then start the, so you just dock the lens and you start injecting. So at this point don't release the pressure. That's the key in any sort of a wound assisted implantation. So it has got this frosted haptics, and so slight bit of handshake is there between the haptics, but they normally, if you wait for about 10 seconds or so, they open up. If they don't open till 10 seconds, then I'll go with the second Sinskey who can physically open them. 10 seconds is about to be up. And so you don't need to actually pull them apart, just pinch on the bulbous end and it should open like this, and
that's about it. And I'll go below the IOL to remove all the viscoelastic. Light में देखिए. Light में देखो ना ना हो गया.
Anything about the injector system, sir? What type of injector system is this?
Basically, this is like it's a screw-based system. So it's not push. So that's very secure actually. I'm not very fond of the injector systems which require you to push, because if there is a sudden loss of pressure, you can inadvertently, throw the IOL anywhere in the eye. So these screw-based systems I prefer for any kind of injection, manual injection. So that's about it. So it's a proper EDOF lens. The contrast and the mesopic acuity and everything, the profile is similar to that of a monofocal lens, with the added advantage that it gives very good near visual acuity, intermediate acuity. About 90% of the patients are spectacle free with these lenses. So that's what you're looking for. So especially in younger patients where the night driving and all those things are an issue, you might prefer this lens over a multifocal lens. BSS और these center करेंगे थोड़ा सा. Eye size is slightly bigger than normal. Vigamox system. Manpreet, any further questions? So this is Vigamox intracameral, and whenever I use a port, I like to hydrate it back, even if I have used it once.
So I think we'll
and
switch.
Just a quick IOP check, and that's the end of the surgery.
Thank you, sir. We'll switch to our next surgery, which is being done by Professor Rajesh Sinha, sir, and he'll be implanting the Hoya Impress IOL. I guess Dr. Weber will be presenting the patient details.
Okay, sir, thank you.
We are presenting a case of 57-year-old gentleman with the diagnosis of left eye posterior subcapsular cataract, and we will be implanting the Hoya Impress lens.
So as we can see, sir has already implanted the IOL.
I'm just doing the
Tell us
Phaco.
something about the injection system of this lens, sir.
Can you hear me?
Yeah. Yes, sir. Yes, sir.
Okay. So right now I just done the nucleotomy, almost finishing the nucleotomy, and I'll be implanting the Hoya Vivity Impress lens, which is an enhanced monofocal lens. So this lens basically is unique in the sense that it has frosted haptic design. Edge of the optic is square and also has a frosted haptic, unpolished edge. So that really helps in preventing the dysphotopic symptoms. So I'm just finished the nucleotomy, and now I'll remove the cortex. Can I have the IA, please? So in that, the Vivity Impress lens is available in a preloaded platform. I'll show you that in just in a minute. It is available in a preloaded platform, wherein the external diameter of the tip of the cartridge is 1.7 millimeters. Now we are doing the surgery through a 2.2 millimeter incision, and so when you are using a cartridge which has a tip of 1.7 millimeters, then the risk of distortion of the wound is absolutely negligible, and that is the advantage. The other advantage is that this is an advanced monofocal lens with with a intermediate vision at 66 centimeters. So if you put the lens in both the eyes, then a large part of the near vision is also taken care of. And can you open the lens, please? Yeah, a large part of the near vision is also taken care of, and so most of the work, day-to-day activities, the patient can do even without near correction. I was just polishing the cortical fibers left inside, and that is it. And now I will inject the viscoelastic sodium hyaluronate into the anterior chamber, and I'll this is the I'll just show you a little bit of this. Can I have the viscoelastic, please? I'll reduce the zoom so that, yeah. So this is the, here you inject little bit of BSS and then some Visilon. You can see the movement of the viscoelastic, and then I'll take this out, push this plunger to lock it, and then take this thing out of the case, and here it is. And now you have the screw system and you have the push system. So whatever you want, you can do it, and you can see here the tip of the cartridge is just 1.7 millimeters. So that is the advantage. It will not distort the wound, and I'll just stabilize the globe with the second instrument, introduce the tip of the cartridge inside, and then I'll push the lens into the bag, and it will go nicely inside the bag. And the biggest advantage is this, that it does not distort the wound. You can see the lens is in the bag, the frosted haptic is very much visible, and there is hardly any difficulty in placing the lens. It has the advantage that it provides an intermediate vision up to 66 centimeters. So if implanted bilaterally, as I said earlier, you have the advantage of a lot of near work that can be done. Most of the things I have done. If there are any questions,
Yes, sir,
you can ask, or else it can be shifted to the other table. I am just removing the viscoelastic from behind the lens first, and then I will remove the viscoelastic from the front of the lens and place the haptics horizontally. Any question?
Yes, sir. So what has been your experience, sir, in terms of dysphotic symptoms with this IOL?
The dysphotopic symptoms are actually negligible because of the frosted design of the square edge.
Right,
See, the square edge is unpolished and frosted, so that is the advantage that you have with this lens. The risk of dysphotopic symptoms is absolutely negligible.
Right, right. And how about the spectacle independence, sir, for like near work and?
Yeah, more, as I said, that the intermediate vision is up to 66 centimeters.
Right, sir.
So if you implant it bilaterally, then most of the near work is done. The laptop work, most of the near work can be done if implanted bilaterally, because unilaterally it can take care of up to 66 centimeters.
66, right, right, sir.
Yeah.
Right.
So now I am just hydrating the wound, and that is the end of the procedure.
Right, sir. It looks
and
wonderful, sir.
I will just dehydrate it, and then I will push the optic in underneath the rexis. It is coming up.
Right, so I think so we'll shift to the next case.
Yeah, you can,
sir. Yes,
yeah,
thank you, sir.
you
Thank
can
you.
shift to the next.
Yes,
Yeah,
sir.
this is how it has been pushed now.
Yes, sir.
You can shift to the next.
Yeah,
Yeah.
thank you, sir. Thank you.
Thank you. Thank you.
Next, we have the Rayner IOL implantation by Professor Namrata Sharma, ma'am. Dr. Himanshu will give us the case details.
Good morning, everyone. Our next case is 55-year-old gentleman with right eye immature senile cataract, nuclear sclerosis grade 2 with posterior subcapsular cataract. He's planned for right eye phacoemulsification plus foldable intraocular lens, that is Ray1 enhanced monovision lens of 21 diopter. Over to you, ma'am.
So I think we've already done all the steps. We just have to.
Ma'am, we're shifting to you now.
Yes.
You're not.
I'm not audible?
Yes, ma'am, you're audible now.
Okay, so we've actually done the phacoemulsification. And again, like I say, you have to see that the bag is completely full. And this is the Rayner intraocular lens which we are going to implant. It is again, I think Rayner was the first company to make the intraocular lenses. And it is a lens again, which is a great lens in the sense that it was designed by Dr. Graham Barrett, and it takes care of the positive spherical aberrations and extends the depth of focus. It has a slightly different design which you can see as opposed to the other lenses, and this design is responsible for its stability. And you can see the injection is quite smooth, viscoelastic. So always when I put the lens, although in this case it is not required, it's become my reflex to put a little bit of viscoelastic to push everything down, limbs, and then to take care of this trailing haptic which is there. So this is in position. It looks quite stable, and the design is different as you have seen. And again, it is an excellent lens which gives very good vision at all distances. Its optics are also excellent. Like I said, Rayner was the first company to come into the intraocular lens market, and basically it treats the positive spherical abrasion. So we are just aspirating the viscoelastic from the anterior chamber. The rexes you notice is slightly larger because of the size of the lens and also because of the haptics which are kind of extended. But it is a lens which is very stable in the anterior chamber, in the capsular bag, and there is a little bit of fragment of cortex there. You can go behind the lens to aspirate those shreds which are present, and again the viscoelastic is out. And we have the study that we have done, you can see, I don't know whether it can be seen in the intrapositive microscope or not, but this lens, if you see the gap between the posterior capsule and the lens, we found in our study that this is minimum. And it is said that the patient has good visual acuity, or the best corrected visual acuity is best when the PC directly touches the intraocular lens. So this is it, and we know that the viscoelastic is out. Once you see those stria which were there in the PC, there are 3 signs that the viscoelastic is out. You can actually see the lens will start jumping or will start moving. You will have the PC stria which are present, and of course you notice these two stria. That means the viscoelastic is completely out. Can we have the IOCT please? DSS. So this is one sign of the fact that we have completely evacuated the viscoelastic. And as we actually hydrate the wound, notice how this stria won't disappear, and it is also related to the it is also related when you hydrate the wound, because the lens then intraocular pressure is raised a little bit and the stria would disappear. So thank you. If there are any questions, I would be happy to take them.
Yes, ma'am. Ma'am, would you like to comment on the injector system of the IOL, ma'am? The size of incision and.
So you have to slightly increase it, Manpreet, but I think it's a very smooth injector, and in this you have to place it. It comes in fluid because it's on a hydrophilic platform which is modified,
Right,
and this is the packing of the lens in which the injector comes, which is the fluid. You have the injector.
Right, ma'am.
And it's a very simple injector, just like you would have, injectors for all the lenses. So there is no learning curve, or there is no trick, or you don't have to relearn it again.
Right.
And again, like I said, this is also one of my go-to lenses because of the excellent vision that it gives.
Right.
There is no dysphotopsia or hardly any dysphotopsia.
Right, ma'am. Any difference in the PCO rates, ma'am, as compared to the other hydrophobic IOLs that we have?
We've implanted, even if you see the literature, the PCO rates are not there. I mean, the posterior capsular pacification or visual axis of pacification is not there in these lenses,
Right,
as you would expect, and that is mainly because of the fact that the design of the lens is such that
Right, ma'am.
it kind of snugs very fitly, it fits very snugly into the capsular bag, and
yes.
there is no this thing between the two. So Manpreet, which is the next case?
So ma'am, next we'll be shifting to Rajesh Sinha sir, ma'am, for
Okay.
the Zeiss trifocal IOL. Yeah. Yes, ma'am. I think we'll have the patient details for that. Thank you, ma'am.
Thank you. Thank you so much. I think this was the last for me today. Okay, thank you.
So our case is 52-year-old lady who presented with diminution of vision more in the right eyes, and we will be doing the right eye Phacoemulsification with posterior chamber intraocular lens implantation for the right eye immature senile cataract nuclear sclerosis grade 2, and we will be implanting Zeiss trifocal lens, toric lens.
So we've shifted to Professor Rajesh Sinha sir. Sir is in between Phaco as of now. Yeah.
Okay, can you hear me?
Yes, sir, we can hear you.
Okay. So this is a 57-year-old lady, and the plan is to do phacoemulsification and put a trifocal lens of, this is a Zeiss 80 Lisa trifocal toric lens, and this is a plate haptic design lens, 11 millimeter overall diameter, 6 millimeter optic diameter. It's a bitoric lens. So the meaning of bitoric is this, that the cylindrical power is distributed in on both the surfaces, both anterior and posterior. Can I have the epinuclear please? So the advantage is, that is the reason why in this lens you can put even up to 12 diopters of cylinders. Like the lens can, this lens can provide you with a 12 diopter of cylinder. That is a huge amount. That is basically because of the advantage of being bitoric. IA please. Sinsky. And can you just open the lens please? So this is an aspheric design and diffractive lens, 80 Lisa trifocal toric. Now you can see there are some fibers that are attached. So with the foot pedal control only, without going into the polish mode, I am just trying to polish it, and remove these small fibers which are almost removed, and now I'll show you how the lens looks like. So can I have Hilon please? So I inject the intraocular lens under the sodium hyaluronate, and can I have the lens please? So this is I'll just reduce the zoom to show you the injector system. This is a unique injector system, Viscoject, and it has this is the lens. This is the system wherein the lens is loaded, and what we have to see is the direction of the arrow. See the direction of the arrow. This is the direction of the arrow. So now we will put it like this. So it is sort of preloaded, but not exactly preloaded. You can see the arrow that is directed towards the cartridge. Now what we have to do is we have to inject some viscoelastic. We will inject some viscoelastic. Then I'll push this plunger up to here so that I get a click noise, click sound, so that the lens is in position. Now the lens is in position, the safety guard is removed. So the safety guard is removed, and now I will close the wings, and then I will push the lens little bit, and now I'll take it into the eye. So with the bevel down, Sinsky please, with the bevel down, and after stabilizing the globe, I'll take it inside through a 2.2 millimeter incision. Maybe there was a little bit less of Helon in the anterior chamber. It was that is why it was distorting the wound little bit, but you can very easily put the second foot plate inside. Can I have the IA please? And now can I have the can you see the axis? I'll just rotate it.
Yes, yes, sir. We can see that. Yes.
So the advantage of this lens is that you can rotate it in both the directions. So whatever direction you want,
right, sir,
you can rotate it.
Yes, sir.
So I'll just rotate it like this. I'm a right-handed person, so I'll rotate it, and
sir, any difference in terms of stability in these IOLs, sir, as compared to the normal C-loop haptics?
Actually, to tell you frankly, both the designs are good. This design, plate haptic design, theoretically shows that it has better stability, but to tell you honestly, there are good designs available, and all have good stability, but yes, this lens, what you want, what one should know is that this lens is good in terms of stability.
Right, sir. Right.
So that is the basic advantage.
Yes.
And since it's a plate haptic design, once it is there, it is there.
Yes.
It doesn't move.
Right.
So I'll just, for the last last few degrees I have left because I have to remove the viscoelastic. So I'll just go in, remove the viscoelastic from the front and also from the back, because it is very essential to remove the viscoelastic from the back in all the cases, particularly in eyes wherein you are implanting a toric lens.
Yes.
Because if there is any viscoelastic left behind, then the rotation of the lens in the post-op period is very high. So that is what I would want to do now. Once the viscoelastic is completely removed, then I will just once again see the axis, whether it is well aligned or not. So it needs just a couple of degrees of rotation, so maybe little bit like this, and it's there. It is there, so I'll remove the remaining viscoelastic and then hydrate the wound.
Right.
So any question for this lens or?
Yes, sir. So as so it's a diffractive design IOL. So again, sir, how has the incidence of dysphotic symptoms with this IOL been? Because I'm sure the near vision must be good, but
Yes, the for near vision, the near add is 3.33.
Right, sir.
And for intermediate, the intermediate add is 1.66. So it has a very good near add, very good intermediate vision. And as far as the dysphotopic symptoms are concerned, it has a special technology, that is SMP technology, which is used. It is a patented technology which is used to reduce the halos in these lenses.
Right, sir.
So I've hydrated. Now I'll just inject the intracameral antibiotics fast. I inject it rapidly from the wound itself. It goes to the up to the bag, and that is it. Just little bit of more of hydration, so the wound is adequately tight, and that is fine.
Thank you, sir, for the wonderful surgery.
Thank you.
Yeah, thank you, sir. Now we'll shift to Dr. Manpreet Kaur's table, and she's implanting an Alcon Clarion IOL today. So the patient details will be given by Dr. Siri.
We have a 67-year-old female patient. So we have a 67-year-old female patient with both eye immature senile cataract, grade 3 to 4, left more than right, planned for left eye phacoemulsification plus posterior chamber intraocular lens under topical anesthesia. In this case, we'll be putting a foldable monofocal intraocular lens of Clarion autonomy platform of power of 24.5 diopters.
Thank you, Dr. Siri. Am I audible?
Yes, you are.
Okay, so as you can see, I have already done the Phacoemulsification steps. So I am ready with the bag filled with a cohesive OVD to implant the IOL. So I'll just show you, it's a unique IOL delivery system, and I'll just show you the delivery system of the Clarion intraocular lens. Just tell me if it's focused, because I'll be shifting it. So this is a preloaded intraocular lens with a unique carbon dioxide delivery system. So step number 1 is, as you can see a hole over here, you take a dispersive OVD. So I am taking a sodium hyaluronate plus chondroitin sulfate or Viscot, and Duovisc is also recommended by the manufacturers, but this is what we use in our OT. So go in the hole straight and inject your OVD till it comes to this line. Okay, so if it's clearly visible, it's this line where you have to stop injecting the OVD. Then the second step, first step was injecting the OVD, is just lift it slightly and pull this outwards. Okay, so this is when you have removed the mechanical part blocking the injector. So now it's ready to be activated. So how do you activate it? just give a firm press first. So now you have activated the carbon dioxide delivery system. Then you do a full press for the intraocular lens to load. So as you can see, the leading haptic folds over the IOL beautifully while it's being pressed. So do stop here, don't keep on injecting, otherwise the lens will come out. So after you have activated the delivery system, don't wait for ages. You have to inject the intraocular lens while the delivery system is still active. So we have a lot of IOLs now, all the Alcon platform is shifting to the Clarion material. Injector wise, this one monofocal is at present available in the autonomy carbon dioxide delivery system. You also have Panoptics Vivity, as was shown earlier in the day, in which you can use an autosert with the Monarch cartridge or a manual injector to inject them. So I'll be showing this unique delivery system. So I'll just use a Sinskey Hick to stabilize. Dock, it's a wound assisted delivery, goes via 2.2. Slight amount of pressure. So you leave it in the bag and come out. Okay. So if you saw, the leading haptic was unfolded and this did not fold properly. It does happen because it's a preloaded system. All I can do is just fill in the Vivity-Ot and load it. Even if it happens, the material is so user friendly, so pliable, that as you can see, there was no issue at all in unfolding, and it has went nicely into the bag and is just sitting there. Right. So what's next is, Mataji light mein dekhe please. What's next is just OVD removal. So Clarion, just coming to the materials. So two unique things in this is, one is the material and the second is the delivery system. So the material has a higher refractive index than the IQ lenses that were previously on the Alcon platform. So that makes it slightly more hydrophilic. So what's the advantage of the hydrophilicity? That there is less glistening and surface haze. So the clarity is excellent. In fact, when you see in the post-op, there's a smile on your face seeing the clarity of the intraocular lens. It's of course a square edge, and as you can see, I am polishing the posterior capsule with the edge only. And then you go beneath and you are left with a shining posterior capsule. The other property of this material is that fibronectin adherence is promoted. So what happens is that the PC will adhere to the posterior capsule and it will prevent migration and proliferation of the equatorial cells and PCO. So I have a slightly floppy iris, small iris in this case. So I'll go carefully in the edge. So you can keep on polishing the posterior capsule, take out any residual cell, and it will help prevent PCO. Anti-light may please.
So since the IOL is loaded in Vivity-Ot, Dr. Manpreet, is there any, do we need to be more meticulous during the viscoelastic removal as such? And
Yes. I think you need to go beneath the lens as well as in front. When beginner surgeons have a hesitancy of going beneath the lens, but I do think it's very important, one, for the lens to achieve its proper effective lens position, and second, to prevent any unnecessary spikes, IOP spikes, and the little amount of fibrosis that creeps in if you leave an OVD beneath the lens.
Correct.
So I do think that to have a healthy shining posterior capsule, you need to remove the OVD completely. As of now, the OVD removal is complete and the lens is well centered in the bag.
Yes, we can see that. It's looking wonderful.
So now we have Panoptics Vivity on this material, IOL material, but I think preloaded is going to be the future. We are moving away from manual injector systems, autosert. Only Alcon came up with autosert. I don't think any other did, though I do think it's a wonderful lens delivery device. But preloaded is the way to go because we are moving to single-use disposables. And this Clarion autonomy is a very nice, does not require you to enlarge the wound if you saw. You just dock in, and of course slightly more force is required.
Yes.
But in the long run it does not distort the wound per se.
Yes.
And gives you a very smooth in the bag IOL delivery. If you see, the plunger is such that I can just gently nudge the lens after injecting, and even the trailing haptic unfolds in the bag.
Yes.
Which I think is one of the uniqueness of this delivery system, which I have found. With others, you are slightly hesitant to go in the bag and push with the plunger, With this, it's so comfortable that it gently helps unfold the IOL, complete IOL in the bag. You don't need a Sinski to tuck your IOL or nudge it. It opens beautifully in the bag itself.
Yes, yes. And in your experience, have you had any failures with injection, or has it been like?
Of course, of course. However, anyone may claim that their devices are 100% foolproof. It's never the case. Sometimes we have had, see, our patients are in topical. So when you're injecting, it's a wound assisted delivery. If they move slightly at that time, so over here you can have the edge of the plunger slightly coming out, and then the lens unfolds outside. So then you need to reload in a Monarch cartridge and a manual injector. So even if we have the bestest of the preloaded systems, we'll still need a backup manual injector in all cases. So all those who are investing in one kind of IOLs, one backup injector is necessary to take care of these problems. And second is, like I said, in this the leading haptic unfolded, it did not fold properly. These are things you cannot rectify. If you're in a manual injector system, you can go and reload it. In this you cannot. So then you have to take care. Like this I said is very forgiving. Not all injector systems are going to be. Again, a backup may be required. Some have had IOLs being stuck in the injectors as well with different IOLs. I have heard reports, read case report series, etc. So device failures are going to occur. It's not that one is inferior or one is superior. It's just the way things are. You are going to have failures. So you need to have backup manual injectors with you.
Yes, but I believe the incidence is not that high. It's
not that high.
Yeah,
not that high, definitely. They are worth the comfort and the ease.
Yes, yes, right.
Any further questions?
I think that's it. Thank you, Dr. Manpreet. Now we'll shift to Phacoemulsification with iStent implantation by Dr. Shikha Gupta. I think we can shift to her station.
बिल्कुल अच्छे से कराया आपने आंटी. आंख बंद कर लीजिए.
Yeah. Good afternoon, ma'am. So we'll have the patient details.
Yeah, good afternoon, Sridevi. I hope I'm audible. So this is a 70-year-old female, and she is a diagnosed case of primary open-angle glaucoma. And she has a pretty brunescent cataract, as we can see. So, and she's on 3 medications with a almost 0.8 to 0.9 cupping. So her pressure is 16 millimeter mercury on 3 medications. So we plan to do a Phacoemulsification for her, and after that we plan to implant iStent W, which is a second generation iStent device. It comes with 2 devices. So we're first proceeding with the normal Phacoemulsification. So we've just done a rhexis and a hydrodissection. So I would want my parameters to be torsional. You can keep the burst mode at 80. Yeah, because it is quite a dense cataract. I can have a Sinski, please. Yeah. So some people prefer to do Phacoemulsification first, while others prefer to implant the device first, because sometimes after Phacoemulsification, especially in situations like this, the cornea can become edematous and hamper our visibility. But I really feel that it helps to do the cataract first, especially if you have an angle closure patient. So where we usually do other MIGS, not iStent particularly, but we can do goniosyneculasis with goniotomies and all of these procedures. So I do, this is primary chop that we are attempting to do, and we've just rotated the nucleus because, so this is multi-level chop where we first do the chopping at the higher, at a superficial level, and then we go deeper at the same level to achieve the chop. And then we go to the last plate to break it. Once we know that the chop has been achieved, our work is almost done. And then we go for the other pieces. So we wanted to show the iStent basically. So now we are dividing the further pieces. So I usually prefer to use Sinski as my second hand instrument, as it helps me maneuver my pieces well. Sometimes we also do hook and flip where we go under the nucleus while we're doing Phacoemulsification. Until the end, I'm not wary of my usage of the second instrument. So, and we do lateral separation of the pieces. So this is how we are achieving it. Once we have done the division of the 4 parts, we take one by one now. We try to keep our Phaco probe at the level of the anterior capsule. Don't put the saline, please. I just want the Visalon. And then one by one pieces automatically come to the Phaco tip at the plane of the anterior capsule. So now this is the last piece. We try to be slow when we are taking the last piece, especially when there is no cortex left in such cases where we have Runesen cataracts. So we'll try and go slow now. You can reduce some parameters, please. Aspiration and flow rate you can do. You can give me IA. So the lens we are implanting for the patient is AIIMS. Those with mild to moderate glaucomas, we do put these kind of EDOF lenses as they do not reduce the contrast as much. But implanting other trifocal lenses are a big no-no for these patients, as they split the light into near, intermediate and distant distance. So, can you wash it? So this is the polishing that we are attempting to do here. लेंस ओपन हो गया? Okay. So this is, we can see it's the posterior capsule is little lax, it's trying to come to the IA probe. You can do polish, please. So we do see such cases in cases of, elderly patients like this one. So instead of aspirating, we're just polishing the posterior capsule to avoid such a situation. So for iStent, I would say that what is the indication? So we try to implant them in eyes with open angle glaucoma, especially primary open angle glaucoma, where the angle is accessible to us. So this is a typical patient that we would like to choose for our surgery. So this is some kind of capsular fibrosis which is here. So maybe the patient can undergo a yak cap later on. Hilon de dena. Yes, IOL please. So this is an AIIMS IOL as we have discussed, and we are implanting it in the bag. So after we inject the IOL, we keep the cohesive viscoelastic inside the bag. We don't want to aspirate right now. And then, so we now start the MIGS surgery. We tilt the microscope to almost like 30 degrees. In the initial few cases, we have an application on the mobile called inclinometer, by which we can see how much tilt we have achieved. And then we tilt the head of the patient. Can we see outside? And look at the patient's, can we show the outside of the this microscope, and we show the positioning of the patient, please. So the head is tilted. You can show this. The microscope is tilted and the head is tilted, right? So almost like 30 degrees is achieved. So surgeon can adjust his positioning because the microscope lowers down according to the new position now. So this is the visualization that we want to achieve. We prefer to do it in the nasal angle, as that's the angle that's shown to have maximum aqueous channels at the outset. So we are inflating the AC here using a visco-cohesive device, and we need to clean the blood. Can you take a swab stick? So we should be taking care that our field is blood free. There is no blood here. And can I have the eye prism gonioscope? So there is a eye prism, please. Have you opened the device? So now you can show the box here to the camera. So this is the eye prism gonioscope. You can open it. Yeah, you can open it here. So this comes with the, you can also open the iStent W. So you can show it to the camera. This is by the Glocos. It's iStent W implant, 2nd generation. And this is the eye prism. So this comes with the device. So we put viscoelastic here. Yeah, on top, beneath the eye prism. And then we try to visualize the angle here. Tilt karo microscope. So we also have to see that we achieve the maximum magnification that a microscope can achieve, and we can all see the angle here. So the brownish line is actually the pigmented trabecular meshwork with kind of blood efflux into it. So this is the structure. The cornea is not so healthy in this patient, so I would say that maybe this is the view we would be able to achieve in this patient. And we aim for the upper border of the trabecular meshwork that we see here. Yeah, little bit, yeah. We will tilt the microscope a little bit more so that we achieve a better view. Yeah, that's all. So this is important, and since iStent is being done by cataract surgeons all around the world, it is important that even the cataract surgeons get equipped with the kind of visualization that a gonioscope achieves. Can I have the inject, please? Yes. So this is the device that I'm holding. Can you show the device outside? So can you show the device on the camera, please? Okay. So this is the device that I am holding in my hand. This is the iStent W. This comes with the injector. So we defocus and try to enter the device here. So we go with the main incision, and after we have gone here, we just retract. We have retracted the sleeve that is over the device. And then focus the trabecular meshwork again. And once that is in focus, we go here near the trabecular meshwork, indent it, and then make sure we are at the right position. We indent it and we inject. And we can see blood coming out from the device, which shows that we have implanted it in the right position. Then for the second device, we tilt the microscope and the gonioscope a little bit, and then go again around 1 to 2 clock hours apart. We dimple again, and then we inject again. We can see the device being implanted in the blood efflux. So that's it. This is the end of the surgery. So we will just see that when we remove it and we do IA, there will be some blood particles. We can straighten the head of the patient and do IA, and we can see that there is episcleral venous reflux. So we position back the patient and the microscope. And then we can see some blood trickling from both the positions that we have implanted the implant into. And we just aspirate it. And we can see that as the blood is being aspirated, there is some blanching of the episcleral venous vein system at 3 to 4 o'clock position. They are less red compared to the other positions. And I think the surgery is done. Any questions?
Yes, Dr. Shikha, so what is the average IOP lowering rate with this device that you've seen in your patients? Yeah.
So for this device, we have to be really selective. Can we have air? And we close under a little higher pressure to avoid bleeding. So it's almost like 25% on an average. The higher the pressure, the greater the lowering. So if we are dealing with the patient with the pressure of, it's occluded. If we are dealing with a patient with a pressure of around 25, we can aim to achieve around 15. And if we are dealing with a patient with 18-20 pressure, then again 15. So we have to know that since the upper limit is the episcleral venous pressure, the IOP cannot go as low as in a trabeculectomy case in these cases. But yes, up to the teens, like 12 to 14 millimeter mercury, we can achieve lowering of the pressure here.
Right, ma'am. And what are the kind of cases that you would recommend putting this device in?
Yes, so moderate glaucomas, I would say, and open angle. So that is my criteria to go to.
Okay.
Angle closures, you will not be able to see the anatomy, and since it's a costly procedure, we don't want to, miss it. So only for open angle primary glaucomas, with moderate glaucoma, borderline control and IOP up to 25 millimeter mercury will also do, but not greater than that.
Right. And ma'am, any complications that you've seen in the
So
post-op?
we may see hyphema. That is one important complication which is usually self-resolving. But this needs to be counseled to the patient because in comparison to a normal phacoemulsification, where patient sees immediately after the surgery, the patient may have slow recovery in these eyes. Otherwise, other than that, sometimes the device may dislodge rarely and may occlude rarely. So other than that, there are hardly any complication. Of course, the efficacy is a thing that with time, as the device may get occluded, the efficacy may also come down. So these days, even the third generation iStent, which is the iStent Infinite, is coming in the market where they give us 3 injects at the same time.
Right, ma'am. Okay. Thank you, ma'am. Thank you for this very nice surgery. We will now shift to Dr. Devang Angmo. She is going to demonstrate the use of a KDB or a Kahoot dual blade. Dr. Avneet will give the patient details.
Good morning, everyone. So this is a 60-year-old male with best corrected visual acuity of 612 in the right eye and 612 parts in the left eye. Intraocular pressure is 16 millimeters of mercury in 16 at presentation and 20 millimeters of mercury in the left eye. Angles were open on gonioscopy, and on fundus examination, cup-test ratio was found to be 0.8:1. So we diagnosed the patient as both eye primary open angle glaucoma with glaucomatous optic neuropathy with immature senile cataract, nucleus sclerosis grade 2. And the patient was planned for left eye Kahoot dual blade with Phacoemulsification with posterior chamber intraocular lens under local anesthesia. Over to you, ma'am.
Hello, everyone. Am I audible?
Yes, ma'am, you're audible.
Okay. So this is the patient. Thank you, Avneet, for the brief presentation. So today I would be demonstrating the Kahoot dual blade excisional goniotomy. So before I go, so KDB, which is in short known as KDB. So KDB is a minimally invasive glaucoma surgery, MIG surgery, and MIG surgery has come into vogue now. So the most important thing before we perform a MIG surgery is the orientation or the positioning of the microscope and the patient. So for this, what we have to do is that we have to tilt the patient's head nearly 30 to 35 degree away from us. Babaji, thoda udhar. And then the microscope will tilt towards the surgeon, nearly 30 to 35 degrees. Making an angle of 70 degrees. So can I have the direct gonioscope Swan Jacob lens? Yeah. Let's go. So I'll just show you the angles of the patient. It's not centered. So is it visible?
Yes, ma'am, it's visible.
Yeah. So this is widely open angle. So I'll just start the surgery and demonstrate. So we can see the pigmented trabecular meshwork clearly here, and I would be targeting there. So the first and foremost thing is to fill the anterior chamber with a high viscosity viscoelastic. 2.2. So I'm here using Helon. Lens is ready?
Yes.
So I'll just show the KDB. So this is how the blade looks like. So is it focused? Yeah. So this is, if you see, this is the tip of the blade which is sharp, and this is the incising part. We just have to indent this into the trabecular meshwork, and this is the tip which is sharp tip which indents into it. Following that is the ramp which actually dilates the Strem's canal, and then we have two parallel blades which are sharp blades that helps in incising the TM, the trabecular meshwork. So KDB is basically incising the trabecular meshwork or the damaged trabecular meshwork, and by bypassing us into the collector channels, bypassing the TM and increasing the trabecular outflow. So the KDB, if you look into the technique, so there are three types of technique. So as I've shown you on the gonioscopy, the angles. So first is the inside out technique. So we start from, if we consider this as 3 o'clock position, we can indent into the TM, and then we can slide down one side and then leave here, and then indent again and slide from in to out. So this is the inside out technique where we do nearly 3 to 4 clockers, 2 clocker down and 2 clocker up. Similarly, we can do from out to in, where we start indenting from the outside, meet at the center on both sides, and then strip off the trabecular meshwork. And the third technique, we mark the 3 to 4 clockers that has to be done. And then we just sweep or excise the TM. This is known as the mark and meet technique. So I'll just be showing the technique that I'm using. So is the lens ready? So this is a direct gonioscope.
Lens ready.
Give me some Helon, इसको center करना है. Can we center this? Helon?
Centration.
Yeah. Please press the centration.
Centration press करते हैं.
Yeah, center the center. Doesn't matter. Okay. So put some coupling fluid. So we can clearly see that, oh, it's not centered. Now is it centered? So is the TM visible? So this is the pigmented trabecular meshwork which is clearly visible.
Yes,
so
it's very well focused.
So I'm doing the mark and meet technique. So I just mark around 3 to 4 clock hours here. So I just indent the KDB, and as you can see that as I am moving my blade, it is gliding through. And as the blade trail is made, you can see a cleft being formed, widening of the Schwemm's canal which is there, opening up. And this is nearly 3 to 4 clock hours that I have done. So mix usually we do 3 to 4 clock hours. So I'll just show you. So there you can see this is the TM that has been stripped out. Can I have the micro forceps, vitreoretinal forceps? Yeah, so I'll just show you. So now we have stripped the TM. Elon. ठीक है, lens. Yeah. So now you can see how the cleft has opened up, and the TM here, I'll just be, so this is the TM that has been stripped off. We can just peel it easily, which smoothly comes out. So this is the TM that is coming out. So advantage of KDB is that the TM can be, so this is nearly 3 to 4 clock hours of TM that has come out. Here it is. So can we put the lens? So here is the angles now, which is now the Schwemm's canal, and here superiorly you can see there is a mild bleed. So the mild bleed indicates, okay, I'll just center it for you. Slightly move the handle of the, yeah. So you can see a mild bleed superiorly. So this bleed is a good sign, meaning that the blood has come out from the Schwemm's canal into the anterior chamber, suggesting that it's a successful goniotomy, excisional goniotomy that has been done. So this is the KDB procedure that has been demonstrated. Thank you.
Thank you, Dr. Devang. An excellent surgery, and that too in a phakic eye. So any special considerations when you do this in a phakic eye? I'm sure it must be much more challenging.
Yeah, so basically after this I have combined this with the Phacoemulsification surgery because the patient has a nuclear sclerosis grade 1 to do. I prefer it in patients who are medically controlled and open angle glaucomas, and maybe ocular hypertensive also. I've also done in patients who have angle closure glaucoma, but I combine that with goniosynculosis with the KDB goniotomy.
So any rationale for doing phaco afterwards and your procedure first, or does the other way around work as well?
So the rationale being that whenever we do the surgery in the naive eye, the anatomy and the tergosity is very good. So you can see the maximal widening and things. So if you do a phacoemulsification, sometimes there can be corneal edema. The bleeding is also more because the eye becomes hypotenuse. So these are the two things that has to be taken care of. So that is why I prefer to do it in a before phacoemulsification.
Of course, this surgery went seamlessly, but any complications that occur otherwise?
Yeah, so MIGS again is a new procedure, so complications can happen. So the first and foremost thing is that one should know your gonioscopy very well. You should know your structures, what you are incising, And if you don't incise at the proper place, iridodialysis has been commonly seen, cyclodialysis, massive hyphemas. So hyphema is one thing which can complicate the entire thing. The hyphema becomes so massive that you cannot proceed with the surgery further. So that has to be taken care of.
Thank you, Dr. Devang. It was a beautiful surgery, treat to watch for us non-glaucoma people as well.
Thank you, Manpreet.
We have been on track, 11:56, and at 12 o'clock session ends. Thank you everyone who's watching for being such patient viewers, and thank you all the surgeons, the nursing staff, the audiovisual team for helping in a smooth conduction of the session. Thank you.
And just to conclude, Happy Women's Day to everyone around me.
Oh, it was a women's show all around.
Yeah.
Thank you.
So, I mean, I feel so good. And
pink is the new blue. Bye.
yeah, so I mean that's again a treat. So many women operating and leading women. So it feels so great. Thanks, Manpreet.
Thank you. Okay, we now conclude the session. Thank you.
I guess you first.